Just did, Carrie. Okay, so your learning objectives are on these first two slides here. And I'm going to start with a video after we do this overview. So we're talking about these congenital heart defects, and then we're going to talk about a couple acquired defects that children can get. I warn, sometimes this video causes tears.
This is Juniper.
Our little June bug. She was born on February 12th, 2014, healthy and normal. Or so we thought. At 2 weeks old, we took Juniper to her first doctor's appointment. Her heart looked a little big, and our doctor wanted us to see a cardiologist right away.
At the cardiologist, Juniper had her first echocardiogram, her first of many. The doctor then told us that our baby had dilated cardiomyopathy, a condition in which the heart's left ventricle is enlarged, decreasing the heart's ability to pump blood throughout the body. In other words, our baby's heart was failing.
4 days later, we were transferred to Children's Hospital, Colorado, and immediately rushed to the cardiac intensive care unit. There, they hooked Juniper up to tons of machines. That's when we understood that we were going to have to make some tough decisions in order for our baby to survive.
After much deliberation, we decided to put Juniper on a left ventricular assist device, otherwise known as a Berlin heart. Simply, this machine helps Juniper's heart pump blood. But it was a temporary solution, a bridge to transplant. We knew she needed a new heart, and it needed to happen quickly.
So we waited. Over the next 6 months, we waited by our daughter's bedside, hoping for a heart every day. Our nurses and our doctors waited with us, keeping us strong and optimistic every day. Then, on September 16th, we found out she was getting a new heart.
In the waiting room during the procedure, it all felt so surreal. We had been waiting for this moment for months, but now that it was here, we didn't actually know what to expect.
We wondered how long it would take for Juniper's body to adjust to the new heart.
We wondered what it would be like to finally take her home.
We wondered how long it would be before she'd be a normal kid again.
We wondered if our baby would even make it through this transplant.
Only 8 days after Juniper's transplant, the team at Children's Colorado sent us home. Nearly 7 months after our first doctor's visit, we could be a normal family again. Finally, it felt real. Up to this point, all Juniper really knew was being in the hospital, and all we really knew about being parents was being there with her. But now, she'd finally be home.
It's been over a year since Juniper's transplant, and I won't tell you that it's been easy. Juniper is still not eating, and we have to give her nourishment through a feeding tube. She's still not talking too much, and she has to work with a speech therapist every week.
We have to give Juniper heavy doses of medication every 12 hours on the hour so that her body does not reject her new heart. But we have our Juniper, our little June bug, with us today because of her transplant, because somebody said yes to organ donation.
Juniper runs around our house laughing, playing, and making a mess like any other toddler.
She loves dogs and can barely contain her excitement when she sees them.
Over the past year, she's traveled to see family and friends around the country.
She's finally getting to have a somewhat normal childhood, and we are getting to picture a future with Juniper, hopeful for what the coming years bring us.
For that, we are forever grateful.
Okay, so that's Juniper's story. If anybody that works at Children's during that time in 2014 kind of knows who she was. She was the youngest patient to ever be put on a left ventricular assist device, or an LVAD, which was that big blue machine that was being pushed around with her. And it worked. We weren't entirely sure what was going to happen, but it worked, and she survived. And she's 6 now. She's doing really well. She's just finishing up kindergarten, and we're going to be talking about her during the lecture. So I'm going to use that example. I'm going to talk about a few things from that video as we go through when we're talking about congenital heart defects, heart failure, and some of the needs that we see with this population. I did know Juniper. I also know Juniper's mom. So here's a really cool connection about Joni. She graduated from DCN, and she's a nurse at Children's. So it's kind of cool to have that connection, that she graduated from our school, right? So she is a big supporter of heart transplantation, or just organ transplantation in general. Juniper has been on multiple billboards and is kind of a spokesperson for Children's. She is about a week younger than my daughter, so they're about the same age, so I kind of have like a personal connection, I guess, in terms of like thinking about her being the same age as my daughter. Is interesting sometimes. It is something that we will talk about a little bit more throughout the lecture, but heart transplantation, unfortunately, with our pediatric patients is still not full life expectancy, like we've been talking about with the kidney transplants and liver transplants and those kind of things the last couple weeks. It's still only about a 15-year life expectancy. That's kind of average. Some patients have lived longer than that, but it's still usually young adults for an infant heart transplant. So this is a child that will not live to be older age, and it's extremely rare to see a patient get a second heart transplant. Just because they are so hard to get in the first place, it's really rare to see a second transplant that happens. So let's talk a little bit more about heart failure and cardiac assessment. So when I'm talking about this assessment, I really want you to go back to thinking about the basics of your cardiac rhythm, your cardiac assessment. What is the normal assessment? Stick with those basics. You know, the color, your patient should be pink and warm, right? They shouldn't be pale or cyanotic or gray. Those abnormals, right? They shouldn't have cool extremities. They shouldn't be diaphoretic. Chest deformities, things like abnormal heaves or abnormal movement on the chest. Now, it is normal to see pulsation with an infant and younger kids because they're usually skinnier. They usually don't have as much body mass there. So it's fairly normal to see a little bit of a pulsation with their pulse. But we're looking at other things like a heave that would not be normal. Respiratory excursion, they're normal respiratory assessment, right? We shouldn't see retractions or tachypnea or shortness of breath, any of those abnormal respiratory things. Clubbing of the fingernails I talked about in the respiratory section with like our cystic fibrosis population. That happens because of chronic low O2 levels. It's not something that we see right away in infancy. It usually takes within the first couple years of life, though, before we start to see that. Peripheral pulses, when you're assessing your pulse sites, should be that normal +2 equal bilaterally, upper and lower extremities, and make sure that you're assessing all 4 extremities, especially on an infant that we're assessing for cardiac defect. There are some of these defects that will make a difference between preductal and postductal, which are my feet, right? So I might see normal pulsations and normal pulses on my upper extremities, but delayed or weak pulses on my lower extremities, cool extremities, and abnormal circulation on those lower extremities, but it might be okay on the upper extremities. Another important part of that when you're assessing for cardiac function with an infant, if you're looking for cardiac abnormalities, is BP, your blood pressure on all 4 extremities, because there will be a difference on a few of these between your upper extremities and your lower extremities. Chest auscultation, listening for your normal S1, S2, S3 can be normal in some pediatric patients. S4 is an abnormal. Things like a murmur would be an abnormal, something like a friction rub or a bruit would be abnormals that we might hear in a patient. Heart rate and rhythm, and remember back at the beginning of the quarter I mentioned that infants have an irregular heart rate. So in that first year of life, it's normal for them to have an irregular rate. They should still have sinus rhythm, but but it will be irregular. And then once we get older than that first year, then usually it'll kind of balance out. It'll be a regular sinus rhythm. All of the dysrhythmias that you find or that you talked about in med-surg, because I know that Will does a lot of those pretty extensively, you can see in a pediatric patient. We see VFib, we see atrial flutter, we see atrial fibrillation, asystole, any of those rhythms that you talked about, we see in peds patients. I will not put a rhythm strip on the test and expect you to identify it, but it is something that we're looking for. Your perfusion, whether they're meeting those output needs. Temperature, they should be warm, not cool or cold. Their urine output might decrease if they're in heart failure. And their nutritional state, because a lot of kids with congenital heart defects have an increased metabolic demand, they need extra nutritional support. And we'll talk a little bit more about that here in the next couple slides. All right, normal cardiac flow. So remember, those inferior, superior vena cavas come into that right atrium, right? That right atrium goes to that right ventricle, and then that goes out through your pulmonary arteries into your lungs. Lungs do that CO2-O2 exchange. It's going to come back in through your pulmonary veins into that left atrium, the left ventricle, and then out there to the rest of the body. Keep that in mind when we're talking about the congenital heart defects. Really, if you have a good understanding of what normal circulation is, it will help you understand what the abnormal circulation is that we're going to talk about today. Listening to those heart sounds is pretty much the same as it is for adults. There are a few exceptions here. So remember the APTMAN, aortic, pulmonic, herbs, tricuspid, mitral, or apical pulse, right? So that order that you're listening. And normally with the aortic, you're starting second intercostal space, right sternal border, then you're moving over to the second intercostal space, left sternal border for the pulmonic, herbs is third, tricuspid's fourth, and your mitral is fifth. There is a slight difference here with peds patients, and this is mainly under school age because their heart is a little bit more horizontal and vertical, that up and down, it's a little bit more sideways. And so that shifts those auscultation points a little bit. And you can see on the slide here, that tricuspid area here, it might be better to auscultate it on the right sternal border instead of the normal left sternal border. The other difference for peds patients is that that mitral or apical pulse is usually closer to the fourth intercostal space when they're younger. Because it's a little bit more sideways, it's a little bit higher up in their chest, so it's usually closer to that fourth intercostal space for that apical pulse. But same order, same things you're listening for. Murmurs for children, sometimes they get what we call flow murmurs just because they have faster heart rates and that blood is going through the heart a little bit more turbulently because it's going faster. You may hear a murmur because of that. Doesn't necessarily mean that there's anything wrong in the heart. A murmur is a blowing, whooshing sound. So if I give you a test question, because I can't give you an audible, I would give you something like the description of it, right? So that blowing, whooshing sound happens because of turbulence, it happens because of a hole, it can happen because of an abnormal valve in the heart. So there's a lot of different reasons that we might hear a murmur. The grading of murmurs is based on how loud they are. A grade 6 murmur is so loud that most of the time you don't even have to touch your stethoscope to the chest, you will hear it. The grade 1s are so quiet that most of you, if you've never heard a murmur before, will not catch a grade 1. They're super, super, super faint, and they're really hard to hear over that normal S1, S2. The grade 3s are kind of where it becomes more reliable that most people can hear a grade 3 murmur. They're usually fairly audible and a little bit more obvious when you're listening to those heart sounds. Remember, we talked about things in health assessment like a systolic or a diastolic murmur or a pansystolic murmur. What phase of the cardiac cycle are you hearing that murmur? Cardiac terms you should already be familiar with: preload, afterload, contractility, your cardiac output, your stroke volume, PVR is pulmonary blood flow. So those are things you should pull in, remember, back from med-surg. Non-invasive diagnostics that we use in the cardiac section. So chest x-rays are something that we use. We can tell heart position, we can tell heart size, and we can see some abnormalities with it. With Juniper, she had dilated cardiomyopathy, which basically means that the heart muscle is too weak and it becomes dilated and distended and bigger, and that muscle and that wall is too thin to pump effectively. So the heart will try to keep getting bigger and bigger as it struggles to pump. So we would see that on a chest x-ray. There's an interesting congenital abnormality called Dextrocardia, where the heart is literally on the opposite side of the chest, and it's crazy to hear for the first time. You're literally listening to all of their heart sounds flip on the right side instead of the left side. There's another disorder where sometimes all of their internal organs are flipped, so pancreas is on the opposite side, liver's on the other side. Those are things we can tell with a chest x-ray. EKGs or ECGs, we have slight differences with where we put the positions of the leads for our pediatric patients. Generally under 12, the leads are in a slightly different position. Over 12, they're where you're going to see with an adult. The big difference is, that heart is in a slightly different position, so it causes a slightly different electrical conduction. I don't expect you to know those differences, but know that there is a slight difference with those leads with younger kids. And it can be challenging with an infant to get those leads onto the right spot, that they're not touching each other because they're like right next to each other on their little tiny chests. Holter monitors a lot of times are things that we can use to send home with a patient. It's like that EKG, but we can get a long-term assessment of our patient's rhythm. And these are great for kids that maybe we're working up for dysrhythmias. There are tiny ones that we use for kids. They're small little ones that we use for kids. And they're synced to smartphones nowadays, so the doctor can get an instant update if there's some sort of dysrhythmia that's happening, and they can help the parents kind of know what's going on. There's a really cool new one that just came out for adults in the last year or two. That's literally just a box. It doesn't have the lead wires or any of those little, tubes coming off of it. It's just this little box that sticks on the chest. Hopefully they come up with a tiny version for kids, because that would be nice not to have all of those wires hanging off all over the place. Echoes are an ultrasound of the heart that can tell us the size, the function, the flow. We can literally look at the blood flowing through the heart and get a good assessment of the heart. Now, these have to be done usually in a dark room when it's quiet and the patient's holding very still. Infants, that's hard to do. So my tip on this for getting a good echo with an infant is wait until it's nap time and wait to feed them until they're in the echo room, because then you can give them a bottle and you turn the light down, and sometimes they will go to sleep and take a nice little nap while you're getting the echo. So they'll hold still for you. If not, then sometimes we have to do sedation to keep them still to get a good echo. All right, here's a tricky one, guys. Exercise stress test. So how do we do an exercise stress test on an adult? Put them on a treadmill. I can't put a baby on a treadmill. So how am I going to do an exercise stress test on an infant? Drugs. Yep. Okay. So chemical. So nuclear isotope that we do, and then we do radiation exposure, and we can do it that way. Yep, we can do it that way. Somebody that got it. Megan got it. Feed them. Feed them is exercise for an infant. So feed them is exercise. Now, a couple of you guys, Amanda put crawl. Crawling for an older infant is something that is exercise, but it's not a sustainable exercise, right? Sometimes I get something like crying as well. It's also not a sustainable, you can't just have them do it, right? Feeding, though, is something that they do every 3 to 4 hours. So it's something that they're doing on a regular basis. And that is exercise, that is work for an infant. So just like we would be doing with the adult that's on the treadmill, we're going to have them on that full CR monitor. We're going to be monitoring their pulse ox and their heart rate and their respiratory rate and their assessment. So what kind of signs would I see if they're not tolerating that exercise stress test? Think about that adult on the treadmill. Think about what you learned with that patient. Okay, fatigue. Yep, increased respiratory rate. Decreased O2 sats. What else? Flushing, potentially skin color changes, right? They could become cyanotic or pale if they're not getting good perfusion. Increased heart rate, absolutely. And kids especially, that is one of the signs that we will see is that increased heart rate. They can effectively increase that heart rate more than an adult can. Good. Yeah, and they may stop eating, right? They may have these like panting or shortness of breath because they're working so hard to get that cardiac perfusion going that they're not going to feed very well. So they may stop feeding. So decreased intake, increased heart rate, increased respiratory rate, the color changes. Diaphoresis on an older infant. Remember, the younger infants don't sweat yet, but an older infant would be sweating. Good. So pretty much the exact same things you would see with an adult on a treadmill, right? So that's exercise for younger kids. Once we hit like toddler age ranges, sometimes we can start looking at them while they're exercising or playing to see how they're functioning with that, because it may not be an infant necessarily that we're doing this assessment on. And then cardiac MRIs give us a really great image. We will do those especially before surgery so that we can get a good image of what the size and function and structure of that heart looks like, because some of these defects we're going to talk about cause abnormal structures of the heart. All right, so cardiac catheterization is an invasive diagnostic that we use. It's also something that we use to correct some of the defects. In terms of diagnosis, we can look at hemodynamics, so their pressures, the flow of blood through the heart, how much blood is being put out at any given moment. We can use it for biopsies to look for signs of infection or inflammation. It is what we do for looking for signs of rejection after a transplant. Normally, our heart transplant patients get a cardiac cath at least biannually, so every other year, to just assess to see if we're seeing any signs of heart failure. And that's usually things like increased white blood cells and those kind of things. Juniper was due this winter for her biannual cardiac cath, and I haven't seen any updates from her mom. Normally she posts them on her Instagram account. She's got an Instagram page called The Borrowed Heart. Normally she puts them on there, but she didn't for this last one. The one that she had when she was 4 years of age showed early warning signs of rejection, but no official signs of rejection. So far she's doing really well. We also use cardiac caths for corrective measures. So some of the defects we're going to talk about today, like coarctation of the aorta, or a VSD, ventricle septal defect, or a PDA, patent ductus arteriosus. Sometimes we can go in and fix that with just a catheter instead of doing open heart surgery. We do stents in kids sometimes, just like we do with adults. Radiofrequency ablation, so the tachydysrhythmias. You guys remember talking about SVT, supraventricular tachycardia, with your adult patients. That is the most common dysrhythmia that we see with peds patients. That's one that we can go in and do an ablation on, where we basically kill off those cells that are causing that hyper stimulation of the heart that causes that SVT to happen. So there's a lot of reasons that we do cardiac catheterizations on kids. Your nursing considerations to think about, these are pretty much the same as your adults. We want to make sure we have an accurate height and weight before they go in. There are risks for bleeding, there's a risk for infection, there's a risk for nausea and vomiting afterwards, loss of pulses, risk of a dysrhythmia, because we went in and we just messed with the heart, so we can cause a dysrhythmia even if we're going in to fix something. So your post-cardiac cath assessment, monitor pulses. Which pulse sites do you need to assess if this is a femoral catheter that's been done? Distal, right? So pedal pulses, distal to that insertion site, so pedal pulses, and you want to make sure you're measuring equal bilaterally. So I've got here temp and color of affected extremity, but make sure you're comparing it to the other extremity, because it may look pink and warm, but it may be decreased from what the normal pink and warm looks like on the other extremity. So you have to compare both of those extremities to each other. You're getting frequent vital signs on your patient. You are inspecting that dressing. It should look CDI, right? Clean, dry, and intact. If it is saturated, what are you going to do? Call a healthcare provider, but first, before, reinforce it. Yeah. Put pressure on it. Don't leave the room. So this is an important thing. If you've got a bleeding patient with a femoral bleed, don't leave the room. put pressure on it. Put pressure on it first. And we usually keep those emergency supplies at the bedside so that you have an extra dressing there at the bedside, right? Yep, put gauze and pressure over it. Do you remove the original dressing? Nope, we're not taking off that original dressing, right? You're leaving the original dressing on and you're going to put pressure and new gauze over that. Here's my one take for any emergency situation that you're thinking about. So we call the healthcare provider, right? Might not be easy to do if you don't have your phone. Most of us carry like phones around nowadays in the hospital, but the code button is there. You always have your code button at the bedside when you're in the hospital setting. Do not be afraid to hit that code button. The worst that's going to happen is that all of those people come rushing in and you tell them what's going on, and half the people are like, okay, cool, you don't need me, and they leave. It's not the end of the world if it's not a true code where you're having to do compressions. If you need help in that room, hit the code button. Now, some places have like the rapid response button, or you can hit like the staff assist button. That might be appropriate in the setting more so than the code. But worst case scenario is you get all the help in there and you don't need it. If you don't hit that button and you need all of that help and you don't hit the button, then you could get yourself into trouble. So I'm always a big proponent of don't be afraid to hit that code button. It is a little embarrassing sometimes when everybody rushes in and they're like, yeah, you're okay, you don't really need us. Not the end of the world. Okay, keep that in mind. Best place to hold pressure is about 1 inch above the insertion site. It's a little hard to do that on infants because it's usually like right in the groin, but a little bit above that insertion site is the best place to hold pressure, not right over the insertion site. And then we want to make sure that we're thinking about fluid intake, your isonose, strict isonose with this patient. There is a huge risk for hypoglycemia, especially with the infants. Remember when we talked about them using that adipose tissue or that brown fat to keep themselves warm? If they've been naked on a table while we're doing the catheter, they're burning their glucose. So we want to make sure that either they've been fed or they have some sort of fluid that has dextrose in it to keep that blood sugar up. But all right, fetal circulation. So I know you've touched on this a little bit in OB. We have the placenta that's going to do that oxygen perfusion for baby, right? We cross the lungs while baby's in utero. Those lungs are not functioning yet. So the placenta is doing all of the work. It's taking all the CO2 out, it's putting the O2 in, and it's going back to baby or away from baby with that umbilical cord, which has your umbilical vein, umbilical artery. Now, because of that, we have differences with our circulation in the heart. We have holes in the heart that allow for that oxygenated blood to come straight in and go straight out to the circulation instead of having to go to the lungs. Keep in mind that your umbilical vein is oxygenated and your umbilical artery is deoxygenated blood, just like your pulmonary vein is oxygenated blood and your pulmonary artery is deoxygenated blood, because it's replacing those two vessels. So let's talk about the fetal heart. So it starts beating at about 3 weeks gestation. You can usually hear it about 6 to 8 weeks. And it has those holes in it that I was talking about. The lungs are not functioning, so we have the circulation that bypasses that. So I've got the two main openings here listed on your slide, the foramen ovale and the Ductus Arteriosus. So I'm going to circle them on the slide. So your foramen ovale is the opening between the atria. It's a hole between the atria. It's a hole in the septum between the atria. The Ductus Arteriosus is this one right here that I'm circling, and that's a hole between your great arteries. So your aorta and your pulmonary artery, those are your great arteries. So it's a hole, a connection between those two. Because if you look at the picture here, you've got this umbilical cord that comes in, right? You've got that umbilical cord that's coming in here, and all of that's oxygenated blood that's coming in. It doesn't have to go to the lungs. It can go straight over to the left side and straight out to the central circulation instead of going to the lungs. The same thing, if it goes into this pulmonary artery here, it doesn't have to go to the lungs there. It can go straight up into the aorta and out to the rest of the body. So that's in utero. When baby is born, we need those holes to close so that we can have normal circulation. So there are two things that happen. One, the lungs start to fill up, and that causes pressure changes in the heart to happen. and that will cause those holes to start closing. So the first hole that starts to close is the foraminal valve, and that starts to close about 1 hour of life. That starts to close at about 1 hour of life. The Ductus Arteriosus starts to close at about 12 hours. I'll put 12 there. About 12 hours. I'm not happy with what I drew. 12 hours of life, and it closes by about 72 hours, so by about 3 days of life. Now there's some further closure that happens with that, but they should be mostly closed by this point. So by about 3 days of life, both of those holes should be closed enough that we have separate circulations that are happening. So what you should see with the newborn is this separate right to left circulation. You've got your deoxygenated side on the right side, you've got your oxygenated side on the left side. Okay. Couple differences as well. Take a look at my infant heart here. Which ventricle is bigger with the fetal heart? That right ventricle is bigger, right? Because the right ventricle is doing what? It's pumping all of the blood out to your central circulation, right? The left ventricle doesn't have to work very hard. But for an adult, an older kid, what ventricle needs to be bigger? The left ventricle, right? So we need that left ventricle to be bigger. So we should have a 2-to-1 ratio by about 1 year of age. So it takes a little while once baby's born for that left ventricle to get bigger. The right ventricle will get a little bit smaller. So your left ventricle should be 2 times the size of your right ventricle by the time you're 1 year of age. So that's another important part of our assessment. And then just remember that that fourth intercostal space is where that apical pulse is usually for younger kids, and the heart is a little bit more horizontal. So those are some differences with your fetal circulation to newborn circulation. This is an important part of assessment. Hopefully everything goes well and those holes close like they're supposed to, and there's nothing else wrong with the heart, and all's well. Baby looks great, but what if something's wrong? All of those things that we talked about with your cardiac assessment, right? Like a murmur, or signs of heart failure, and unequal pulses, or blood pressure issues, breathing issues, poor growth, failure to thrive, and activity intolerance. And that could be feeding for a younger kid or play for an older kid. So you guys talked about acrocyanosis versus cyanosis with your newborn assessments. So looking at this baby, what do you guys think? Acrocyanosis or cyanosis? Good. And how can we tell it's acrocyanosis? Yep, no central cyanosis, right? So we're looking at the lips, we're looking at that circumoral cyanosis, or that core, that body, right? The core central perfusion is what we're looking at. It should be nice and pink. You guys can see these lips are nice and red, bright red. That's what we should see. But you can see the hands are purple, and that's that acrocyanosis. It is very normal to see that last a little bit longer in Colorado because our environment is a little bit lower oxygen. Especially in the mountains, we see the purple hands and feet last a little bit longer, and sometimes it lasts through the first couple months of life, especially when babies are cold or crying. The hands and feet will go purple, but you should still see nice central circulation perfusion. So looking at this baby, what do you guys think? Yeah, we've got central cyanosis on this kiddo here, right? You can see that we've got the purple lips on this kiddo. That's what that looks like. That's circumoral cyanosis. And you can see the cheeks and the forehead are kind of pale. Okay, so that's an important part of your newborn assessment. If we have a baby that's cyanotic, first thing we always think about is respiratory. Remember, respiratory is at least 50% of morbidity with kids, so it's almost always thinking respiratory. What could be causing this with respiratory? If respiratory has been ruled out, cardiac is the next thing that you want to think about with that baby that's cyanotic. And then we might have some other things that we could think about, some maybe potential infections, toxins, like mom was taking drugs during pregnancy that could cause it, metabolic issues, and hematologic issues. Those are things that could also cause it, but almost always it's going to be respiratory or cardiac in nature. So, baby is cyanotic or acyanotic. Those are the things that we're looking for when baby is born. And the heart defects that we're talking about, the congenital heart defects that we're going to be talking about, there are two main categories that they're classified in. Cyanotic, whether they're going to be blue at first, or the acyanotic patients. With the cyanotic defects, this is usually something that requires immediate attention, and it may not be detected in those first couple days of life. So remember those holes in the heart that were there that don't close usually until at least 72 hours of life. So those holes can allow bypass to happen and allow baby to compensate. So we don't always see the cyanosis right away. But with the cyanotic heart defects, usually it's going to be either immediate or within the first couple days of life that baby is going to be cyanotic. It usually presents pretty fast. With the acyanotic defects, we may not see any symptoms of this for years. Sometimes this is an adult that we don't even know that they had a heart defect until they're starting to have signs of heart failure. So this is something that usually is a little bit more of a gradual progression. With some of the more significant acyanotic heart defects, like Juniper's story, where she had that dilated cardiomyopathy, within the first couple weeks of life, we start to see signs of heart failure. So tachypnea, tachycardia, hepatomegaly. And those are usually symptoms that we see worse around feedings, because that's that exercise, that's that work. So the baby that's feeding might start to get a little bit blue, maybe a little bit pale. They sweat a lot more. They take longer to feed. Those are some of those warning signs that we start to see with acyanotic heart defects. One thing I will make a note of, and you guys might want to star this, something along those lines, your OB HESI. Because this is a newborn assessment that you are doing, sometimes it's tested on the OB HESI because it's part of that newborn assessment. So sometimes the cardiac congenital heart defect stuff is on your OB HESI, but we cover it in peds because it's a pediatric disorder. Okay, so congestive heart failure. This is inability of the heart to pump an adequate amount of blood to the systemic circulation at normal filling pressures to meet the metabolic demands of the body. And remember, those metabolic demands for children increase as they get older. So right-sided heart failure, inability of the right side of the heart to pump effectively. So where are my main symptoms going to be with right-sided heart failure? Is this lungs or body? It's body, it's systemic, right? So this is the hepatomegaly, this is the ascites, this is edema, that weight gain from that edema, jugular vein distension. Those are usually things that we see with right-sided heart failure, because the right side of my heart is not able to push it to the next step, which is the lungs. It'll start backing up into the rest of the body. Good. Left-sided heart failure, where are your main symptoms going to be? These are the lungs. So the left side normally pumps to my systemic circulation. So if it's not pumping it out, it's backing up into the lungs. And so we start to see the shortness of breath, the dyspnea, the cough. A lot of times they have a cough, this wet sounding cough, and they may have bloody sputum because all of that congestion is backing up into the lungs. Can you see both of these happening at the same time? Yeah, absolutely. We can see left-sided and right-sided heart failure happening at the same time. Yes. So the signs and symptoms can be divided up into what's actually happening versus these are the symptoms only with left-sided or these are the symptoms only with right-sided. It's important to know what you might more frequently with one side or the other, but the signs and symptoms can be divided up slightly differently. So whether we have impaired myocardial functioning, which is going to happen with left and right-sided heart failure, or pulmonary congestion, or the systemic venous congestion. So I just have them broken up here on the slides here. Signs that we have decreased myocardial function. These are systemic signs that our patient's not getting enough perfusion. Things like the tachycardia, the pallor, the restlessness, the decreased urine output, maybe some cardiac abnormalities with their rhythm, or they're hungry, pale, cool extremities, decreased pulse size. Those are signs that we're not getting enough perfusion. The pulmonary congestion symptoms, the tachypnea, the orthopnea, which is that shortness of breath that happens when they're laying flat, cough, wheezing, grunting, exercise intolerance, which is play for kids, nasal flaring, any of those respiratory symptoms. the systemic venous congestion, that's the weight gain or the ascites, hepatomegaly, JVD or that neck vein distension. And I've got children in parentheses on the slide there. Babies don't have necks. You can't assess JVD and an infant. They don't have a neck. You can't assess for it. So you won't see that until they're older, just because they will have necks by that point. All right, let's take a break there before we get into treatment and more information about what causes heart failure with kids. So it's 2:50 now, so let's take 10 minutes. So we'll come back at 3 o'clock and keep going with this. All right, you guys ready to keep going? Awesome. Okay, so let's talk about treating congestive heart failure. So we talked about the signs and symptoms, and removing the cause are one of the things that we do to treat congestive heart failure. So with Juniper, she was in heart failure from a very early age, and the underlying cause was a congenital heart defect that was not treatable. So we had to put her on a transplant list and do that left ventricular assist device. A lot of the congenital heart defects are what we see causing congestive heart failure in peds patients. We don't see heart attacks that randomly happen that cause heart failure with our pediatric patients. Most of the time, what we're seeing with peds patients are the congenital heart defects, which we're going to talk about today. Improving cardiac function with digoxin, which we're going to go over in a second. Removing all of that extra fluid that can accumulate with medications. Lasix is the most common med that you'll see used for that. We want to decrease their cardiac demand, which means rest, and then increasing tissue oxygenation, which a lot of times is things like giving oxygen. So, digoxin, the desired effects for this. We want to increase our cardiac output, right? Because we have decreased cardiac output if we're having heart failure. We want to decrease that heart size. We want to decrease that venous pressure, and we want to relieve that edema that's happening. So digoxin basically makes the heart pump more effectively. It is a high alert medication. It's a double check in most healthcare facilities for pediatric patients, just like narcotics are. So you have to have that second nurse that double checks that you have the right medication. It comes in for oral. It comes in 50 micrograms per ml. So keep this in mind. If you are giving oral medication for an infant of digoxin and it comes out to more than 1 milliliter, you miscalculated. We're giving very small amounts to children with this digoxin. So it's like 0.2 milliliters sometimes is all you're giving for an infant, especially the younger infants. So we want to make sure that we very, very carefully calculate our dosage. That means teaching parents how to very, very carefully calculate, because these children are going to go home sometimes on this digoxin medication, and they need to make sure that they are measuring it out correctly so that they're not overdosing or underdosing or not giving it inappropriately. Remember, we have to check that apical pulse before we give digoxin. What is the rate that we're looking for with an adult? What did you learn in med-surg? 60, right? So the heart rate needs to be greater than 60 before you can give that digoxin. With children, remember the heart rate is faster. So we have slightly different numbers we're looking at. With infants, it's 90 a minute. With younger kids, so this is our toddlers and our preschoolers, it's 70. Once they hit school age adolescent, then you're using that 60. And generally what you'll see on an order for digoxin is going to be that patient's baseline. It'll typically say something like hold if heart rate less than 70. So you'll have a guidance on that, but this is the textbook test answer for this. If you have an infant, it's 90. If it's a child, it's 70. Adolescents, you're going to hit that 60. So keep that in mind. Remember that a low potassium level can cause an increased risk for dig toxicity. Your digoxin level, remember we're doing dig levels that we're testing their blood, so we're looking what those dig levels are. What do you remember dig levels should be? What do you remember from med-surg? Or sim, because I think you guys may have done this in sim. Good, that's close. Emily got it. Emily got the answer from the book. So I think in med-surg, you guys learn 0.5 to 2. And whoever said no more than 2, Amanda. So the general book answer on this one is 0.8 to 2 for our digoxin level. That is the HESI textbook answer for this. Every facility that I've worked in has slightly different lab levels that they're looking at. So the hospital that you're working in may have a slightly different number that they're looking at based on their calculations. But the textbook answer that I want you to know for digoxin is 0.8 to 2. So that's what you should be memorizing, 0.8 to 2. And that's generally the same for adults that you're looking at. It's usually close to that. So that's the level of dig that we're looking for. If they have dig toxicity, what signs and symptoms might we see? Nausea and vomiting. Yep. The low potassium level. Yeah, because that increases that risk for toxicity. Bradycardia and dysrhythmia, so low heart rate and a risk for dysrhythmias. And there's one more. There's one more subjective finding. Anorexia, yeah, they don't want to eat sometimes. Yep, the nausea and vomiting, diarrhea sometimes. Yeah, GI disturbances. You guys remember what it is? That would be the dysrhythmias, yeah, the weird EKGs. So it's the lights, yeah. So halos, or like a ring around the lights. Sometimes they see like a halo or a ring around the lights, so they get visual disturbances. Now with an infant that can't tell you that, sometimes you'll see infants like doing the rubbing their eyes and they seem like they're squinting maybe or rubbing their eyes. That might be something you see with a younger kid that can't verbalize that they're having visual disturbances. Good. So parents need to look for these signs and symptoms. They need to be educated what these signs and symptoms are if their child is on digoxin. The GI disturbances like nausea and vomiting. I just realized I have a typo on that slide. The nausea and vomiting and anorexia symptoms that we see, it's very common that kids get gastroenteritis and they get sick with illnesses that can cause nausea and vomiting. Any kid that has nausea and vomiting that's also on digoxin has to have a lab level check to make that nausea and vomiting is not related to the digoxin. So those are important things to keep in mind. And education for parents. All right, other nursing considerations. So growth and development. So in the video with Juniper, they talk about the fact that she needs speech therapy. She has nothing physiologically wrong with her that would mean that she would have trouble speaking. It's because of that delay from being in the hospital for the first 7 months of her life. That's a huge developmental period, and kids will be delayed because of that. Any amount of time that they're spending in the hospital, especially in those early ages, can cause delay in their growth and development. So physical therapy, speech therapy, occupational therapy, those are all things that cause delays sometimes in kids that spend that much time in the hospital. We really have to think about changing up their environment, making sure that we're giving them other stimulus activities like they would get outside. But it's different for a kid that's in a house that normally goes in and out and maybe goes outside or interacts with other people. In the hospital setting, a lot of times all they see are their hospital room and maybe like a wagon ride around the hospital. They don't get a ton of those normal growth and developmental things, and that does cause some delays sometimes. Exercise intolerance is also something that causes problems, right? If they're fatigued when they go out and they exercise and they play, then they're not going to play as much, and that causes delays in their growth and development. So we really have to think about that goal there. Observing for signs of the ditch toxicity like we talked about. Now, maintaining the nutritional status. So this one, the nutritional status. This is one that can be challenging. Remember I mentioned that they have an increased metabolic need because they work harder, because it takes them more energy to get appropriate circulation through the rest of their body. They have an increased metabolic demand. With Juniper, do you guys see the NG tube that was in her nose for most of the scenes that they showed before she went for heart surgery? And then she had the G-tube afterwards, right? And they talk about the fact that she still wasn't eating very much and she still needs her nutrition through her G-tube. Again, there's nothing physiologically wrong that would mean that she can't eat, but when kids are little and they need that extra nutritional support and it takes them too much energy to eat, we give them G-tube feeds or NG feeds. And then they don't get that oral stimulation and they don't learn to eat. And then they have this oral aversion that happens. Remember with the kids, we talked about like the fistulas and the pacifier being something that's really important when they're getting those NG feeds. That's also something that you want to think about, is that oral stimulation is important, whether that's a pacifier or sucking a thumb or something along those lines. And try to do that while they're getting that NG feed. One of the other things that we'll do sometimes with kids that don't tolerate feeding themselves is if they will tolerate half of their feed through the oral route, but then the other half on G-tube. So sometimes you'll see an order that'll say, give 1 ounce by mouth, and then give the other 2 ounces of their 3-ounce feed by the NG tube. So that way they're getting some of that oral stimulation, but we're not overworking their cardiac demand. and then they get that extra nutrition the rest of the way. So that's something that we sometimes will do, is like we'll try a little bit of oral feeds to prevent some of that oral aversion that happens, but not every kid will tolerate that. The other thing that we'll do is increase the calories. So in babies, they can't necessarily drink more fluid, so we'll increase the amount of kilocalories per ounce. So typically normal formula is about 20 kilocalories per ounce. This baby might be getting 24 kilocalories per ounce. So they're taking in the same amount of volume, but higher calories per volume. In an older kid, that may be a kid that needs nutritional supplementation or extra protein powder added to like a smoothie in the morning so that they're getting extra nutrition in those feeds that they're taking in. Okay, increasing rest. I talked about in the respiratory section with our asthmatics that sometimes they'll go out and they don't recognize that they're having respiratory symptoms, and they're playing and they're like and they're wheezing and they're out playing still, and they're not able to recognize that they're having distress. That's true for these kids as well. Sometimes they will be continuing to play and they'll be purple from head to toe because they're putting too much workload on the body and they can't recognize that they need to rest. So we need adults, we need teachers, we need parents, we need coaches, anybody that's around that child that's having heart failure to recognize what those symptoms are and get them to rest. And sometimes that does mean saying, you need to stop doing this activity, let's sit down and read a book, or let's do a quiet activity instead of playing this board game that maybe is getting you too worked up. Because that extra workload on the heart puts them at risk of potential bad outcomes. Respiratory risk factors. Kids are so at risk of getting respiratory illnesses, and a respiratory disorder like RSV on top of that cardiac disease could cause death. So we want to protect them, and decrease that risk factor with those respiratory illnesses. Remember I talked about RSV and the Synagis vaccine that we have for babies? This would be a baby that's going to be high risk that we would give that Synagis vaccine for preventing RSV. Monitoring fluid intake, they are on strict ISNOs. This is a kiddo that's going to have decreased fluid administration in terms of their fluid intake. If you had to give a fluid bolus, remember I talked about that 10 to 20 milliliters per kilo. This is a kid that's going to be getting that 10 milliliters per kilo because we need to give a decreased amount. Education and support. So I've got up there grief, fear, and anxiety. In the video, they mentioned before she went to surgery, they weren't sure if she'd make it out of that surgery alive. That's a very realistic expectation for a significant surgery, like a heart transplant. That fear is almost always there for parents that have children with these heart defects, because something like a dysrhythmia can happen and they may die from it. So helping support them through those unknowns and help give them, some reassurances when appropriate is helpful. Children with heart transplants don't live to be old adults. They may live to young adulthood or teenage years. And we want to make sure that we're giving that child the best outcomes possible and give them a normal childhood experience. We don't want them to just say, oh, well, you've got this, disorder that you're going to die from by the time you're a teenager, so you don't have to go to school. No, we want them to have those normal childhood experiences. We want them to be in school. We want them to have a normal childhood of growing up and experiencing the same things that kids their age are experiencing. The other side of that with an infant, especially with a transplant, is that for that child to survive, another family had to lose their child. An adult heart cannot fit into an infant's chest. It just doesn't fit. So they have to have a pediatric or an infant that has died for their child to live. And so there's sometimes that secondary grief that happens from that, of knowing that somebody else's family is grieving the loss of their child while their child is living, which I think is part of why Joni has named their page The Borrowed Heart, because it really is that, right? It's this piece that's allowed their child to continue living for an extended period of time. So those are harder things to think about in helping families grieve potential loss. All right, the heart defects. So congestive heart failure, a lot of times caused by congenital heart defects with our peds patients. 0.8% of all live births have a heart defect. That accounts for about 1 in 100 children born with a heart defect. That's about 40,000 kids a year that are born with a heart defect. Do you guys know it was that frequent? that surprise you? Am I having delays on my video? Nobody answering. Okay. We have a lot of deliveries at work with heart defects. Yeah, so 1 in 100. That's the statistics on this. It's pretty frequent. Now, most of them are usually more mild defects, like an ASD or a VSD, which are ventricular septal defects, or an ASD is an atrial septal defect. And sometimes those defects are so minor that we don't even know about them until they're adults. So, and I know sometimes this is a scary statistic, especially for those of you that are young and haven't had kids yet. And it might be a little scary to think about that potential for having a child with a heart defect. So, small percentage overall, but it is something that we see frequently. Approximately 90% of these heart defects is a combination of genetic and environmental factors. It's not just one that we see linked with this. There are some high risk factors, like some medications that we know about, drugs taken during pregnancy, increased risk factors, those seizure medications that I talked about that can cause a lot of defects, that's been linked to congenital heart defects. There is a genetic link here too. So if there's a positive family history for having a parent with a heart defect, that's an increased risk factor for that child to have a heart defect. I had a case several years ago with a mom who delivered over at university. She had congenital heart disease. She had coarctation of the aorta and had been corrected as a child, hadn't had any issues with it. When her baby was born, we found out that the baby had coarctation of the aorta, and he had pretty significant symptoms and had to go right across the street to Children's right away, and he was corrected. And we found out afterwards that the same surgeon that had corrected mom had corrected baby. So it was kind of a nice connection there, and they both did really well with it. But we do see those links. So if we're thinking about the differential diagnosis of an infant that's not doing well, we know there's a positive family history of heart disease or heart defects. We want to assess that heart very carefully. Megan, you had one when you were born. Do you know what it was? Always told a flap that didn't open. Okay. Okay, I'm not sure what that could be. Maybe Tricuspid Atresia, VSD maybe, but that's usually a hole, so it's a hole that didn't close. So yeah, VSDs are really common, and some of them close on their own. So we're going to talk about those defects today. So basically, these congenital heart defects increase workload on the heart. They can cause pulmonary hypertension and inadequate cardiac output. I had a friend whose heart was on the right side. Oh yeah, Dextrocardia. It's a really interesting disorder. Okay, you remember those main overriding categories that I talked about, the acyanotic or the cyanotic defects, whether they're blue or whether they're pink at birth, and then we start to see signs of heart failure. So those are the two kind of old classifying ways. We now have further breakdown of these acyanotic versus cyanotic. We're going to start talking about the cyanotic defects first. Under the acyanotic defects, we've got increased pulmonary flow here. So the ASD, the VSD, and the patent ductus arteriosus are all ones that we're going to talk about. So I want you to star those, whatever. The obstructive flow disorders, the coarctation of the aorta, aortic stenosis, and pulmonic stenosis are also ones that we're going to talk about. These are the more common disorders that we see. And then under the cyanotic defects, I'm really only going to have you focus on two while you're studying. We're going to go over several of these, but I want you to focus on two to know really well for your studying purposes. So with decreased pulmonary flow, tetralogy of flow is the one that I want you to know there. And then under mixed flow disorders, transposition of the great arteries is the one you know there. So we're going to start talking about these, and this is where you need that little heart handout. So get your little heart handout ready. I did add some heart slides into the lecture here, and I'm going to draw on the slides to demonstrate this. Normally I draw this up on the whiteboard, but We're going to do it on the slide here. And this is what I'll save and send this out to you guys. So with our ASD, which is the first one that's listed on that acyanotic heart defects, if you take a look at your heart sheet, you've got the very top row there that says left to right. So this is where you're going to start drawing these. So and there's those left to right, an atrial septal defect and ASD. So we are going to draw our 4 chambers in the heart here. So you've got your 4 chambers. If you have an ASD, an atrial septal defect, you have a hole between the atrium. And this could be a tiny opening, this could be a very large opening. This is sometimes also called a patent foraminal valve, which is that foraminal valve that babies have in utero. If that doesn't close, it's called a patent foraminal valve. Okay, so we've got a hole here in the atrium. Now, if I have blood in my heart, and I have a hole here, I've got blood in these chambers here, right? So I've got blood in those chambers, and I've got a hole there. Is it going to want to move from left to right or right to left? Think about the normal function of your heart. Which side of your heart has higher pressure? Tell me which side of the heart has higher pressure. Your left side of your heart has higher pressure, right? So we've got much higher pressure on the left side. Why? Why does the left side have higher pressure? Yep, the ventricle is bigger, and it has to pump systemically, right? So my left side has to have stronger perfusion, stronger push, because it has to pump blood from up here all the way down to my toes and my brain, right? So it has to have higher pressure. So if I have a hole here in my heart between the atrium, it's going to want to go left to right, because it's going to go path of least resistance, which is high pressure to low pressure, right? The left side has more pressure, so it's just going to go back over to that lower pressure side. The right side pumping the other way is pumping against the pressure. It's not going to be able to do it. So this is going to go path of least resistance. So blood is going to go back over to that right side. And then from there, it would complete that normal circuit. So that right atria down to your right ventricle. And then from where does it go? My lungs, right? So remember, this is under increased pulmonary flow. So that blood that normally would have been pumped out to the rest of the body is going back over to the right side, back to the lungs, and then it'll come back into this left side. We'll still get a little bit that comes down into that right ventricle or the left ventricle and pump out to the rest of the body. But it's not going to be as much. The heart's going to have to work harder to do that. Okay, that's an ASD. A VSD. Ooh. Tapped on it twice. So a VSD, we have that hole between the ventricles. So I've got blood in my heart, right? I've got blood in all 4 of those chambers. If I've got blood here and here, where's it going to want to go? It's going to want to go back over to that right side, right? Left to right shunt. It goes from high pressure to low pressure, path of least resistance, high pressure to low pressure. And then it goes back over to that right ventricle, which will then go back to the lungs. So again, why this is increased pulmonary flow, because instead of that blood going back out to the systemic circulation, it goes back over to the right side and back to the lungs. Is my patient going to be cyanotic or acyanotic with this defect? Acyanotic, right? Because it's still oxygenated blood that's circulating out. I still have oxygenated blood moving around the heart, moving around the body. That's why this is a defect that causes acyanosis, and we will eventually see signs of heart failure as that heart has to pump harder to get enough blood out to the rest of the body. Okay. So patent ductus arteriosus. Okay, patent ductus arteriosus, a PDA. So remember, this is one we talked about that's normal in utero. When baby is born, it needs to close. If it doesn't close within those first couple days of life, it's called a patent ductus arteriosus. This defect is important when we have children that have cyanotic defects, that this stays open. And we'll talk more about that when we get to the cyanotic defects. But normally, for normal heart function, we need this to close. So if we have blood in the heart, I've got blood going through the aorta, and it gets to this pathway where it can go one way or the other, which has higher pressure, my aorta or my pulmonary artery. Your aorta has higher pressure, right? Because it's pumping it out to the rest of the body. So if it gets to this opening here, it's going to go path of least resistance back down to that pulmonary artery. So it goes from high pressure to low pressure, aorta to the pulmonary artery and back to the lungs. So increased pulmonary flow, right? Because that blood is making that circuit back to the lungs, which will then come back in to here and then go out to here and make that circuit again. Now, I'm still going to get some blood that's going out to my systemic circulation, but it's not going to be as much as it normally would be because some of it's being lost back to that pulmonary circulation. Which side of my heart has to work harder for this? What do you guys think? Which side of the heart is going to fail first? What do we usually see with this? Yes, left side. It's the left side because that left ventricle is going to have to squeeze harder to get enough blood past that diversion to get it out to the systemic circulation. So I typically usually start to see this heart muscle get bigger and bigger and bigger. I usually see left-sided hypertrophy because that left ventricle is going to have to work harder to get enough blood out to the systemic circulation. So we'll eventually start to see left-sided heart failure with this kiddo. All right, that's the PDA. Coarctation of the aorta. Okay, so we've got our aorta there, right? Your aorta there coming off that left ventricle. The coarctation, or sometimes a coarc is the abbreviation that you'll see with this one, is a narrowing down of that aorta. So you can see where my little arrow is pointing to that narrowed portion there. And again, this could be a small little bit of a defect. It could be further down or further away. So we've got blood going through the heart. It's going to get to this arrow part, and it's going to cause problems getting blood flow past that. So this is a obstruction disorder. So that next row says obstruction, right? So this is obstruction of flow because we've got this narrowed portion here that's causing obstruction of blood flow out of that left ventricle. What side of my heart's going to fail first with this one? What side's having to work harder? That left ventricle, right? That left ventricle has to work harder because it's going to have to squeeze harder to get blood past that coarctation. It's kind of like hypertension, where your body has to pump harder to get all that blood past that high pressure. This is the same thing that's going on here. We've got that left ventricle that's having to work harder to get blood past that to get enough out to that systemic circulation. Is this starting to make a little bit of sense? Okay, good. Anybody need me to go back to any of them? Okay, we'll keep going. All right, aortic stenosis. So I have my aorta coming off that left ventricle, right? What does the word stenosis mean? If I had aortic stenosis, what would that mean? Think back to med-surg. So narrowing and stiff, right? So this is a narrowed or stiff vessel. This could be the valve itself, or it could be the vessel itself. So, oh, I just heard a crash upstairs and my kid is screaming. Oh, my husband's upstairs. I hope she's okay. Sorry, that definitely distracted me. Okay, narrowing or stiff aorta. So we have this vessel here, right, that's narrowed and stiff. So we have this vessel that's going to become narrowed and stiff, right? It's going to block off flows. This is another one of those obstructive flow disorders. So if I have aortic stenosis, which part of my heart is having to work harder to pump against that? Yeah, that left side, right? We're going to get this left-sided hypertrophy again, because that left ventricle is going to have to pump harder to get blood past that narrowed, stiff opening. Good. Pulmonic stenosis. This is almost the exact same thing that we were just talking about, except we have the pulmonary artery, right? You've got your pulmonary artery. So you have your pulmonary artery, exact same thing that's going on here with pulmonic stenosis. You have that narrowed, stiff pulmonary artery. It's narrowed down, it's stiff here. That's going to cause that blockage to happen, obstruction. What side of my heart's going to first with this one? What side has to work harder? Exactly, that right ventricle is going to have to work harder, right? So we've got this right ventricle that's going to become hypertrophied because it's going to have to work harder to pump against that obstruction. Okay, those were the 6 cyanotic heart defects. Because all 6 of those, your patient is still getting oxygenated blood out to the body, but in most cases, it's going to be a decreased amount. So eventually it will be decreased perfusion, which will lead to signs of heart failure. And that could be very rapidly, or it could be really, really slow. Some of them we don't see until they're adults. So cyanotic heart defects, right? Okay, they're called left to right shunts because it is that oxygenated blood going back over to the right side, or sometimes those obstruction flow. So we're still getting oxygenated blood out to the body. And this slide here shows those different ones, either increased pulmonary flow or obstruction of flow from those ventricles. All right, these are what the pictures look like if you're looking at an actual heart. So the ASD here, that can be a tiny little opening or really wide opening. The VSD, again, tiny little opening or a wide opening, and that coarctation of the aorta there. And that could be anywhere along the aorta. It could be a tiny piece. It could be a barely narrowed opening or really, really narrow opening. All right, cyanotic defects. These cyanotic defects, these are right to left shunts because we have that deoxygenated blood on the right side of my heart that's going to get shunted over to the left side, and then it goes out to your systemic circulation. So your patient is getting variable levels of deoxygenated blood out to their peripheries. So they are going to be cyanotic. And that is a variable degree of hypoxia that will happen with these defects. Some of them, they will die rapidly within the first couple days of life if they're not intervened on. Some of them they can have a little bit better functioning with. I have the T's on the slide here, and if it helps you remember terrible Tara because I'm teaching you these today, then so be it. But they start with the T's. So decreased pulmonary blood flow is tetralogy of flow, tricuspid atresia. The mixed flow disorders is transposition of the great arteries, total anomalous pulmonary venous return, Truncus Arteriosus, and the one exception there is the hypoplastic left heart syndrome. So if you get to a test question and you're like, oh God, I don't remember, is this a cyanotic or an acyanotic or what's happening? If it's a T1, it's probably the cyanotic defect, right? So keep that in mind. The cyanotic defects start with T's. On your little paper sheet, with your little hearts on the last row there, it says right to left shunts. So the first box, I want you to write tetralogy of flow underneath. That's the one we're doing there. You can put TOF. The last box that says mixed, put transposition of the arteries, or that TGA. Those are those two cyanotic ones that I really want you to pay attention to. Now these defects cause a lot more dysfunction with the heart. So we're going to watch a video with these. I want you to pay attention specifically to the two that I want you to remember. It's going to go through 5 main types of cyanotic heart defects, and I'm going to use my little mouse and kind of circle or point out the areas that he's talking about in the video, and then we're going to go back through them and talk about them in a little bit more detail. I don't have hearts though for us to draw, so make sure you're drawing them while we're going through the video.
Wireless battery pack. I'm excited. Let's see what's inside. I really like the build.
This is a brief video on cyanotic congenital heart defects. We're going to be talking about 5 cyanotic congenital heart defects. And these heart defects are called cyanotic because they result in the mixture of deoxygenated blood with oxygenated blood, and then pouring of that mixed blood into the systemic circulation. So these congenital heart defects can cause cyanosis in newborns, in infants, and even in older patients. And that's why they're called cyanotic congenital heart defects. We're going to be talking about 5 defects listed across the left there, and they each have a number assigned to them. That number is going to serve as sort of a mnemonic to help you remember these 5 defects. So let's jump into number 1 of the cyanotic congenital heart defects, and that is Truncus Arteriosus. This one's labeled with a 1 because we have one big vessel in the middle of the heart. This big vessel is called the Truncus Arteriosus, which comes from the heart during the developmental stage. Usually this Truncus Arteriosus is split with a wall that splits the aortic and the pulmonary arteries. And now this did not happen in people who have this disease, so we call it a persistent Truncus Arteriosus. And we can see that blood kind of mixes between the two ventricles before going out into the pulmonary circulation and into the systemic circulation. So most patients also have a ventricular septal defect with persistent Truncus Arteriosus. You can kind of see that in the picture there too. The ventricles don't really have much of a septum between them, allowing for even more mixture of blood as it's pumped into the aorta and the pulmonary artery. This is persistent Truncus Arteriosus. We see mixed blood going into both sides of the circulation, both the systemic and the pulmonary circulation. Next one, we have 2, which is transposition of the great arteries. This one's called 2 because we have 2 great arteries and they're both switched. Now the great arteries are the aorta and the pulmonary artery. These are usually attached to the aorta is usually attached to the left ventricle, the pulmonary artery is usually attached to the right ventricle. In this case, they're switched. And this is a very interesting disease because it results in 2 separate circulations of blood. The right side of the heart is pumping through the systemic circulation, and that's like an isolated system from the left side of the heart, which is pumping through the pulmonary circulation. So in order for somebody with transposition of the great arteries to survive, they need at least 1 shunt. This could be an atrial septal defect, a ventricular septal defect, or a PDA, a patent ductus arteriosus, which is a connection between the aortic or the aorta and the pulmonary artery. So they need some kind of connection between left and right heart to allow for mixing of the blood to allow for them to survive. In that image that we have on the right there, we see an atrial septal defect. That's allowing for the mixing of the blood, turning it purple to pump through the systemic circulation, allowing for the patient to survive. Next, we have 3. 3 helps us remember tricuspid atresia. There's not much to do with the 3 here, except for the fact that it has to do with the tricuspid valve, except we don't have a tricuspid valve. Instead of a valve here, we have a wall. Tricuspid atresia is the tricuspid valve being replaced with a solid wall that you cannot get past. So this means that in order for the blood to complete a circuit, you have to have both an atrial septal defect and a ventricular septal defect. Blood needs to be able to flow into the right atrium from the superior vena cava, through to the left atrium through an atrial septal defect, down into the left ventricle, and then back to the right ventricle through a ventricular septal defect. We need both septal defects in order for somebody with a wall replacing the tricuspid valve to survive. This is Tricuspid Atresia. 4 helps us remember tetralogy of flow. Tetralogy means 4 things. We have 4 odd things going on here. These 4, we have them labeled A, B, C, D, and also labeled in that right diagram. And these 4 are A. First one is pulmonic stenosis. The pulmonic valve is thin. It's hard for blood to get through. We're going to skip over to D because I see it kind of as a direct result of A. D is right ventricular hypertrophy. If we're not easily pumping blood through the pulmonic valve, if we have pulmonic stenosis, A, and we cannot pump blood through it, the right ventricle is going to get much larger as it struggles to pump blood. This is a compensatory mechanism, right ventricular hypertrophy, as a result of pulmonic stenosis. So that explains A and D. Next we have B. B is a overriding aorta, meaning that the aorta, which usually kind of points to the left ventricle, is pointing into both chambers here. The aorta is taking blood from both the left and the right ventricle. Normally it just takes blood from the left ventricle. And kind of going along the same lines as the overriding aorta is C, which is a ventricular septal defect, which essentially kind of connects the 2 ventricles. We don't have much of a septum between the left and the right ventricle, which allows the blood to mix in between the ventricles and go mostly into that overriding aorta. So these 4 qualities contribute to the tetralogy of flow. And lastly, 5 letters in total anomalous pulmonary venous connection. Total anomalous pulmonary venous connection. 5 words, 5 letters in the abbreviation. This is an interesting disorder because both veins, both large veins, the pulmonary vein and the superior and inferior vena cavas, both dump into the right atria. So we have mixing of blood right there, right before it gets into the heart in the right atria. Now, in order for a patient to survive with this, it needs to be associated with an atrial septal defect to allow that mixed blood in the right atria to go into the left atria and then go through the systemic circulation that way. We sometimes also see a patent ductus arteriosus. Again, that's a connection between the aorta and the pulmonary artery, and that can help with the mixing of blood and the connection between the left and right circulations here as well. This is total anomalous pulmonary venous connection.
Okay, so those are the cyanotic heart defects. So I'm going to share my lecture again. That last one specifically, those patients will not survive past infancy, especially the first day, if we don't correct those defects. Because once that PFO closes, the patent foraminal valve closes, they can't survive. They have to have that opening to survive. We're going to go back through that in a second here. Okay. So tetralogy of flow. There are 4 things wrong with the heart with tetralogy of flow, right? Tetralogy of flow. There are 4 things wrong with the heart. What are they? So, okay. All right. What's the first one I'm circling here? Black. What's that one? Pulmonic stenosis, right? Okay, so pulmonic stenosis, that pulmonary artery is narrow and stiff, just like we were talking about, right? The next one. Right ventricular hypertrophy, right? Specifically right-sided hypertrophy. Now, let's think about these 2, right? We just talked about pulmonary stenosis with our acyanotic defects. Why is this disorder a cyanotic defect? So remember that pulmonary stenosis. This one is listed under the cyanotic defects as decreased pulmonary flow, right? Because of that pulmonary stenosis, they're going to have decreased flow to the lungs. The other side of that is we've now got this right ventricular hypertrophy, as well as the other two parts of this, right? So which side of my heart now has higher pressure because of that right ventricular hypertrophy? My right side now has higher pressure. So instead of this being that normal left-right shunt because of that opening, this is going to be a right to left shunt because we now have higher pressure over here. So this blood is going to want to go back that way because it's higher pressure. All right, what's this one here? What is that one called that I just circled? Overriding aorta. Yep, so that aorta is taking blood from both ventricles, basically. Normally, that aorta should be really just on that left side. It should just be on that one side of the heart, and it's taking blood from that left side of the heart. But because it's kind of overriding, it's going to take blood from both sides. It's going to take deoxygenated blood and oxygenated blood out to the rest of the body. And then the other piece of this one, yep, we need that VSD to be there, right, for this to happen, so that it's taking a little bit of blood both ways. So we have the four things, right? Pulmonic stenosis, your right ventricular hypertrophy, the overriding aorta, and the VSD, the ventricle septal defect. And this is going to be decreased oxygenation to the rest of the body. Now, a lot of these kids with tetralogy of Fallot, normal stats are between 75 to 85%. Now, it depends on how significant their defect is, but they are going to have low oxygen levels because of a little bit of deoxygenated, a little bit of oxygenated blood going out to their systemic circulation. They cannot get to 100% because they will always have some of that deoxygenated blood moving through there unless we correct it, unless we fix it. It's not quite half in some cases. It just depends on how bad their defect is formed, on whether they're getting half. I've seen some kids with their stats lower than the 70s to 80s. It just depends on how bad that perfusion is going and when we catch this, those kind of things. Yeah, but they're always going to be low. Regardless, they're always going to be low. All right, the last one that's on this slide here is hypoplastic left heart syndrome. He doesn't go over that in the video. I'm just going to touch on it. It's not one I want you guys to memorize. But this is a cyanotic heart defect, basically because this patient has this tiny, tiny, tiny little left ventricle, right? So hypoplastic left heart. There's no left ventricle that develops there, and so they will not be able to have adequate perfusion to the rest of their body because of that. We do have corrective means that we can do to correct this. There's a 3-stage procedure surgery that we have to do for this. This used to be palliative care only. Kids that were born with this, it was, let's make them comfortable because they're going to die. We now have a fairly decent ability to correct this disorder depending on how bad it is when they're born. And a lot of kids with this are living to be older and they don't have as bad of a quality of life. But it is a pretty severe disorder when they're born with that hypoplastic left heart. All right, so let's go through the names again. So these are the most common disorders. You can see how there's a check mark next to them. They're the ones that I told you wanted you to know. The BSD and ASD of PDA and the tetralogy of Flow. Those are the most common cardiac disorders that we see across the board with kids. Out of that 1 in 100 that are born with it, these are the most common ones. The next most common, ASD, coarctation, and the pulmonic stenosis. Notice those check marks. The other two that are on there don't have check marks. The ones with the check marks are the ones I want you to know. And then out of the mixed congenital heart defects, these are pretty rare. Transposition of the great arteries is the one that I want you to know. That's the one where the aorta, instead of being on your left ventricle, is on the right ventricle. The pulmonary artery, instead of being on the right side, is on the left side. They're flip-flopped. They're on the opposite sides. So correction for those will be to put them back in the right spot. That's about 5%. And the other ones are so rare that we don't even have percentages for those because we don't see those very frequently. If you are working at a cardiac facility, like Children's Hospital here is a cardiac facility. The hospital that I worked at before I started in Colorado was at Lucille Packard, which is Stanford University's Children's Hospital. It is one of the top cardiac facilities in the world. You will see children with these rare cardiac defects because they're going to come to the area where there's a physician that specializes in that. If you're working at a smaller facility or a general pediatric ward in a smaller hospital, you may never see these defects because they are that rare. They need to be treated by pediatric cardiac surgeons. So it kind of depends on where you're working, whether you'll see these. Okay, let's take a break there before we start getting into the defects and the signs and symptoms and the treatment for these defects. So let's take another 10 minutes. It is 3:51 now, or 3:52 now. So come back at 4:02, please. Get up, stretch, do some jumping jacks, get some coffee. I know these are intense, like brain heavy activities that we're doing today. All right, guys, I'm back for more fun. Who likes cardiac? Who's finding this interesting? I know it's challenging. I know it's a challenging topic. I remember being a student going through this. All I remember from class was being like, what the hell is she talking about? I don't know what any of this is. But it gets easier the more you study it, and really knowing like which side of the heart has higher pressure, which has lower pressure, and what the normal flow is will help you understand what these defects are. Yeah, it is tough, but it's interesting. The one thing that I will say that's helpful is that little red HESI book. I think that has a good overview. Your textbook has some great information on it, but it is a little overwhelming in terms of content. The little red HESI book has some really good, like, simple pictures. And if you practice drawing these out, it will also help you kind of understand the basics behind it. All right, so we're going to go through the defects, some of these defects again, and talk about what we do to correct them. So the ASD, the atrial septal defect, we've got more blood going to the right side. Remember, this is a left to right shunt. They may be asymptomatic, especially with smaller openings. The one thing that we see with this sometimes is they have that PFO, patent foraminal valve, that doesn't close, and we sometimes don't even know about it until they're adults. This has actually been linked to migraines in adults, and we've been finding that if it gets closed, it actually fixes migraines for patients. So ASDs, small opening, big opening, depending on what the treatment is going to be. A lot of times we can just go in with a cardiac catheter to fix some of these, and that's either with a patch device or a closure device. I've put a picture on the slide here on one that we use. This is kind of like a stent, except instead of opening it, this is a patch device, and it goes in there, it goes over the little hole area, it pops open, and then scar tissue will build around that opening and that little device and close that area up. So it keeps blood from going to the different sides. The VSD, the ventricle septal defect, another left to right shunt, right? So this is one that is a lot of times associated with other defects like the tetralogy of Fallot patient. So it's always just a VSD. But what it is, it can be a very simple defect to correct. We may not see any symptoms of this if they have a minor defect. With more significant symptoms, we may have more signs of heart failure. There may be more of a risk of having a murmur. Any of these defects with like the holes in the heart can cause a murmur to happen. And an interesting thing about the VSDs is that 20 to 60% can close spontaneously on their own in that first year of life. So if they're not having symptoms of heart failure, we'll continue to watch, we'll do echoes, we'll look for signs that has closed up. If it doesn't close on its own, then we use something similar to like the patch device that I just showed you with the ASD. Sometimes we do have to go in and open them up a little bit more with more extensive surgery, especially if it's related to something like another defect like the tetralogy of Fallot. The patent Ductus Arteriosus, or PDA. So this is more blood going back to that pulmonary circulation. This is a left to right shunt again. They may be asymptomatic or have signs of heart failure. One of the things that we see with patients with PDAs is a specific murmur. So I'm going to underline it there, machinery type murmur. This is a murmur that is considered more of a pansystolic murmur. Remember we talked about either an S1 or an S2 murmur. This is what's happening during all phases of that cardiac cycle, because it's something that is not in the valves or in one of the ventricles or the atrium. It's outside of that area, so you can hear it during all phases. It basically sounds like a constant blowing, whooshing sound during all phases. It's always there. If you Google search it, you'll be able to hear what that sounds like, but that's a specific name for the murmur that's associated with the PDA. We may also see wide pulse pressures or bounding pulses with this patient. All right, so treatment for this one. Infants. Remember, this should normally close by about 72 hours of life. If that does not happen, we need it to close, and we give a medication called indomethacin. Does anybody remember what class of medication this is? Think back to pharm. It's an NSAID. It's an NSAID medication. So indomethacin is an NSAID. It's like ibuprofen. Sometimes we just give a dose of ibuprofen. So indomethacin, it's an IV medication that we can give. Anybody remember what the action of mechanism is in this medication? Decreases inflammation, decreases pain, right? But how? This is important to remember. I know it's in there somewhere. Good job, Natalie. It inhibits prostaglandins, so it's a prostaglandin inhibitor. So it blocks prostaglandins. So blocks prostaglandins. So we give this medication, it blocks those prostaglandins, and it will cause that area to close up. Indomethacin is an expensive medication, so sometimes we just try ibuprofen first to see if that works. A small dose of ibuprofen to see if that works. All right, so we're blocking prostaglandins, which are something that is normally circulating in higher quantities post-delivery. Normal hormones, those kind of things, are higher after delivery. So we're blocking those prostaglandins, which will cause this area to close. Might be totally wrong. Yeah, sometimes it is given to preemies because sometimes that hole doesn't close appropriately as it normally would with premature babies. Yep, so you may see it given with a preemie infant. Okay, so we're giving indomethacin or a prostaglandin, a prostaglandin inhibitor to close that hole up, right? And then, so if that's what we're doing to close it, let's think about the cyanotic defects that we talked about, like the transposition of the great arteries or total anomalous pulmonary venous. Remember we talked about that they needed those shunts, that ASD, that atrial septal defect, or the PDA to stay open longer for them to survive so we can do surgery. So if I need this PDA to stay open, what do I give to keep it open? Think about what we just talked about. Prostaglandins, exactly. Yep, it's just that simple. We give prostaglandins to keep it open. We give a prostaglandin inhibitor, like indomethacin or ibuprofen, to close it. This is an important one to remember. Star that one. And sometimes this is when they bring up on that OB HESI too, or OB assessment, because it's a newborn. This is a prostaglandins is a continuous IV infusion that we're going to continuously administer those prostaglandins to keep that PDA open for a child that has those openings there, or something like a cyanotic defect, to keep that open until we can take that child to surgery. It's considered an emergency medication. Like every emergency room that I've worked in as a peds nurse always has it handy. You'll have it in a newborn nursery, you'll have it in the NICU, because it's a medication that we give in those kind of situations. Okay, if we want the area to close and that medication doesn't work, then we may go in for surgical correction. Sometimes that's just a cath where we'll go in and we'll tie it off, or we'll close it up, or put a coil around that area to close it off. Normally that PDA turns into, or the ductus arteriosus turns into the Ductus Arteriosus is a ligament, and it's just a little ligament between those two areas there. But, all right, coarctation of the aorta. This is a narrowing of the aorta. Again, it could be a very small opening, a big opening, and it may cause no symptoms until the children get older, depending on how bad it is. Now, this is one because they get decreased perfusion to their lower extremities. We may have high pressures and bounding pulses in the upper extremities, but decreased perfusion in our lower extremities. Those legs are going to have decreased perfusion. So cool extremities, decreased blood pressure in your legs. With older kids, sometimes we see just mild symptoms, like the kid maybe gets frequent headaches or fainting episodes with kids that have minor defects. If they are younger, under 6 months of age, it's going to be surgical correction. And the picture there shows what that looks like. We basically cut that area out. We put the two other ends back together and fix it. If it's a older kid, we may go in and do a balloon angioplasty where we basically put that balloon in with a catheter and expand it and stretch that area open. All right, tetralogy flow, 4 things: the VSD, the pulmonary artery stenosis, the overriding aorta, and the right ventricular hypertrophy. Those 4 things cause the signs and symptoms that we see with this patient. Remember, this is a cyanotic defect. It's classified as a decreased pulmonary flow because of that pulmonary artery stenosis. This is an infant that's going to be cyanotic, usually fairly evident at birth or within those first couple days of life once those openings close. And that's a variable degree of cyanosis. They cannot get to 100 until we fix it, until we improve that heart function. And sometimes this is a palliative surgery only. Depending on how severe their defect is, sometimes we can only give them more function, but we can't completely correct the heart based on how bad it was when it was formed. Sometimes we can do complete repairs. You guys know who Shaun White is. Most of you guys know who Shaun White is, the famous Olympic snowboarding athlete, right? He had tetralogy of flow when he was an infant and was complete repair. And now he's an Olympic athlete at high elevation, right? He's a winter athlete, regardless of how you feel about him personally. It is impressive on what we can do when we can correct these defects. So there's a lot of kids that have complete repair that have no long-term impacts with some of these cyanotic defects. One of the things we see with tetralogy of flow patients are these acute hypoxic episodes called TET spells. And I'm going to talk about those in a second. Congenital heart surgery is something that we have to do with these defects. Sometimes it's fully corrective, sometimes it's just palliative. Some of them require staging procedures, like the hypoplastic left heart. We can't completely fix all at once. We do like a little bit of a tweak, and then we go back in and do a little bit of a tweak, and then we'll go back in and fix it a little bit more. Some require full bypass procedures. Some of them are cardiac catheter. This is not an ICU level class, so I'm going to just touch on a couple of the things here that we see with congenital heart surgery. This is what a child looks like after they have had heart surgery. And in the video with Miss Juniper, they showed you 1 or 2 scenes of her right afterwards with like a whole wall of pumps on the pump, syringe pump there. It's a pretty extensive procedure, but in Juniper's case, she went home a week after having a new heart put into her body. So as long as it goes well, they can recover very fast. This is what this kid will look like after he had this open heart surgery. You can see his nice little scar there. This is another example of open heart surgery postoperatively. These are chest separators. Sometimes we do that while they're healing initially. You guys can see that there's a little wire coming out of the chest here. Those are internal pacing wires. So sometimes if we need to do pacing for like a dysrhythmia or something like that after surgery especially, we will have these pacers in place so that we can do that. Basically, our primary goals of doing cardiac surgery is to decrease oxygen and cardiac demands and balance out what is available for the patient, which is why sometimes we do palliative procedures to give the kid a little bit more function as they get older. Medications you see used. Oxygen is considered a medication, especially for patients with heart defects. The cyanotic heart defects, a lot of them you do not want to just give them oxygen. Hypoplastic left heart, you can literally kill that patient with oxygen. Just giving them oxygen can kill them. So oxygen is considered a medication. It needs to be used very cautiously. You need to know what their baseline oxygen level is and think about that when you're treating them. The kid with tetralogy of flow, knowing that their baseline oxygen levels are usually between 70s to 80s. If that child ends up getting sick with a respiratory disorder and their normal baseline oxygen level, let's say, is 85%, and they get sick with this respiratory disorder, they come in and then they're hanging out at 82%. You're only going to give them enough oxygen to get them back up to what that baseline is, which would be that 85%. You're not going to try to get them up to 90s because it's impossible because of that underlying defect. So oxygen used cautiously with patients with cardiac defects. Sometimes you'll see the inotropes like dopamine and butamine, the digoxin like we talked about, Lasix to get rid of all that extra fluid. And then nursing considerations post-operatively, things like respiratory and cardiac issues, risk for infection, risk for bleeding afterwards. I'm just going to talk about a couple of these in a little more detail. So post-op cardiac complications. Unfortunately, we can end up having congestive heart failure that happens after surgery because of inflammation and damage on the heart. Sometimes that's a complication that happens. Dysrhythmias can happen, any of the ones that we talked about, and treatment is mainly the same with peds patients. Cardiac tamponade, so fluid or blood filling up that pericardial space. The signs and symptoms of this, those kids are going to come out of surgery with a chest tube. That chest tube, if it was draining well before and all of a sudden stops, not the kid that was draining and then it slowly diminishes to the point where they're going to go home and it stops, right? This is a kid that all of a sudden has stopped drainage. And we start to see symptoms of decreased blood pressure, decreased oxygen perfusion. Their heart sounds sound decreased. The best way I can describe this is, you know how water makes sound muffled? That's what the heart sounds sound like. They sound like muffled because you're listening through fluid, basically. And then cool peripheries, decreased perfusion, decreased cap refill, decreased color to your patient. Because this is what's happening. We have all of that fluid that's filling up this pericardial space, and it's compressing that heart. So instead of this nice refill of filling up that heart, it's compressed down. So it can't expand, fill it with blood, and push it out to the rest of the body. So you're going to have decreased perfusion. Anybody remember what the treatment is for this? Pericardial centesis, yeah, so it's a giant needle into that space, or a chest tube into that space to drain off that extra fluid that's building up there, right? And it could be serous fluid, it could be blood. I think on drama shows, like Grey's Anatomy and those drama shows, medical drama shows, they make this seem really dramatic. They're like, I have to do a pericardial centesis, somebody grab the needle, and they like stab it into the chest, and you know, the patient all of a sudden sits up and is like, oh, I feel so much better. That's not how it happens in real life in most cases, especially with a post-cardiac surgery patient. We are looking for this symptom before that happens. And most of the time it's a little bit less dramatic than that. It's like, oh, all right, we've got to do this. Somebody get the sedation, somebody grab the chest tube, and then we take the kiddo in to correct it. The drama usually happens a little bit more in the ER with those patients that we don't always know that's happening, like the car accident patient that ends up having it happen. Sometimes that's a little more dramatic, but not post-cardiac surgery. Because we do these chest x-rays on a regular basis on our patients that just had cardiac surgery, and we're assessing for this frequently. This is what it looks like on a chest x-ray. This is what their normal heart size and structure should look like. This is what it looks like when they have all that fluid accumulation around there. So we look for that. Respiratory complications. Post-operative patients always have these respiratory complications. Atelectasis, respiratory edema, pulmonary effusions, pneumothoraxes, a pneumonia. So think about things like your incentive spirometer, getting them up, coughing and deep breathing, those kind of things. Neurosymptoms, seizures, strokes can happen afterwards. We can get a risk for blood clots that can end up causing those CVAs, those strokes. Hematologic issues, anemia, post-op bleeding, and TED spells, so special circumstances, TED spells. So this is a tetralogy of flow patient, so a TOF, tetralogy of flow patient. They go into TED spells, which are these hypercyanotic spells, where basically they get an increased amount of shunting of that unoxygenated blood from the right side of the heart, shunting over to that left side and going out to their systemic circulation. We see this commonly with kids that get stressed out when they start crying and they get really, really upset and freaked out. That is an often triggering episode. Pain is also something that can trigger this to happen. So these are kids that we a lot of times need to keep a little bit calmer and a little bit more quiet so that they don't go into those TED spells. And I've had kids on a cardiac unit that went into frequent TED spells that we kept sedated so that it would keep them going into these frequent TED spells. And they can drop their sats really fast. I've seen kids that were, hanging out in their 80s, normal 80s, drop into their 20s and 30s very rapidly within a couple minutes. They'll go blue, just super, super fast. So treatment for this, when they go into a TED spell, this is a situation where I'm saying, yes, give 100% O2. So whether you've got a non-rebreather handy or that bag mask handy, put it on them, give them 100% oxygen. The knee to chest position is a position that will help increase our perfusion to our heart and our brain where we need it during this TET spell. So this is that knee to chest position in the picture on the slide. With a baby, it's helpful if you have the parents at the bedside to give the baby to the parents with the oxygen on them, and then put the baby kind of to the parent's chest. So we've got that comfort from the parent, and you've got them kind of squished up in that little ball that has that knee to chest position, and calm them down as much as possible. Morphine will also help with vasoconstriction, will help improve that core circulation that we need during that time. TET spells can be scary. Kids can have recurrent TET spells. This can be something that an older kid might be experiencing, especially with a TOF patient that was not repaired completely. They had a palliative procedure, so we may have an older kid that has these happen. Older kids usually know what to do. They'll usually put themselves into like a squatting position, like they'll go down into that squatting position with an older kid that's not a baby. So those are TET spells. And this is the picture from your book, like the core perfusion that decreases. And they go like head to toe purple sometimes. I worked on one cardiac unit that we called the blueberry patch because they were all blue at various degrees. Okay, special situations. So another one that we have to think about is when we have those right to left shunts, when we have that deoxygenated blood that comes in here and shunts over to the left side and goes out to your central circulation. IVs, specifically those venous IVs, not a central IV, but a venous IV where we're giving medications. You remember we teach you, don't let any air bubbles get in, right? You got to get all those air bubbles out. Generally with healthy patients, a tiny air bubble is not a huge deal, but bigger air bubbles can cause an issue. But the little tiny ones, not a big deal. However, with the right to left shunt, what happens if that air bubble gets in there, and it goes over to that right side of the heart, and it gets shunted over to the left side, it goes out to your circulation, which can end up directly in the brain. So this can be an air embolus directly in the brain. We don't want that to happen. It will kill our patient. So those kids need special IV management. We use extra filters and very, very cautious administration with their IVs. So they will have a filter that goes on the end of their IV. It's usually like a round filter that attaches to the end of the IV tubing before it goes into the patient, and that will catch any extra air bubbles that may have been missed by the pump. The pump itself also needs to be set to the highest setting to catch air bubbles so that they don't get past that pump and end up into the patient. So that's another special circumstance with right to left shunts. All right, we're going to talk about a couple acquired defects. Bacterial infective endocarditis. So this is an infection in the heart. That endothelial lining of the heart gets inflamed and can cause things like dysrhythmias, can cause symptoms of an infection for our patient. It can cause valve damage. Basically, that bacteria can attach itself to the valve and destroy the valve so it no longer opens and closes correctly. And a lot of times kids need valve replacement if it has affected the valve. Otherwise, if it's affecting just the general endothelial damage, we need to treat it before it causes a dysrhythmia or causes heart death. The staph and strep are the most common causes. I've got strep up here on the slide specifically, especially patients that are between the ages of 5 to 15. Things like strep throat are high risk for them developing this, which is why we treat strep throat pretty easily in our pediatric patients. Generally, adults getting strep throat, a lot of times we can fight off that bacteria ourselves without getting antibiotics, but kids between that age of 5 to 15 are a little bit higher risk of developing secondary impacts from those strep infections. So clinical manifestations of endocarditis can be vague, unexplained fever, just general like flu-like symptoms where they're tired, their body aches. They may have a murmur. They may have a pericardial friction rub. They may get splinter hemorrhages. Rarer with kids, but that can happen. Petechiae sometimes throughout their body. They're tired, they're fatigued, they don't want to eat. Treatment for this is going to be high-dose antibiotics, usually with a central line. They get 2 to 8 weeks of IV antibiotics and good cardiac management. So in the hospital setting, especially in the acute care setting, they're going to be on a full CR monitor with frequent cardiac assessments done on that patient. Once they go home and they're a little more stable, then it's not as high of a risk, but especially in that immediate period, they're going to be higher risk. Prevention of this, any patient that's had cardiac surgery, or valve replacement, they need those prophylactic antibiotics before procedures, such as like the dental procedures. They need prophylactic antibiotics to prevent this from happening. I had a kid that died from this a couple years ago. She presented to the emergency room after having been sick at home for a few hours with some vomiting and dehydration. She had been treated for a strep infection a week before that. She'd gone to her pediatrician, she'd gotten antibiotics, she'd taken her antibiotics and was doing better. So a week goes by, mom lets her go to Elitch Gardens to hang out with some friends, and the next morning she ends up with some vomiting. And so mom just assumed that it was a gastroenteritis, something along those lines, and was trying to give her some fluids. But by the afternoon, she wasn't doing so well. She was a little bit sleepier, just wasn't acting herself, so mom had brought her in. We started an IV on her. We gave her an IV bolus, and the nurse that was caring for her had gone on break, and I was covering for her. So I went in, heard the IV pump beeping, went in to do repeat vital signs on a patient that had gone on bolus, and I got her blood pressure, and it was lower than it had been. Her heart rate was higher than it had been, and she just looked a little bit worse. She's a little bit more lethargic and a little bit confused and just wasn't acting herself. So I was like, okay, this is not normal. Normally I should have seen the blood pressure increase and the heart rate go down after a bolus. So I went and got the CR monitor, put the leads on her. I'd grabbed the doc in the meantime and said, hey, you know, the kid's not looking so great. Can you come in and with me and take a look at her? We go in the room, I put the leads on her, turned on the monitor, and as soon as I hit on the monitor, BTAC showed up. So it's that wide complex, the one that kind of looks like this just wide wave patterns. From the instant I turned on the machine. So it was one of those, like the doc and I looked at each other and went, shit, scooped up the kid, took her into the trauma room and started coding her, and we couldn't get her back. We lost her. We worked on her for about an hour and never got her back into a rhythm. Post-mortem, we do autopsies on most pediatric deaths because it's not normal for kids to just drop dead like that. So we did a post-mortem assessment on her, and it came back as a strep infection in the heart. So that strep infection had already ended up in the lining of the heart and caused that irritation to happen that threw her into a dysrhythmia and caused her death. There were 2 kids that summer that ended up dying from a strep endocarditis like that. And we don't know if there was like a resistant strep bacteria that was going around because she had taken her antibiotics. It was just enough to cause that irritation in the heart to cause that dysrhythmia to happen and cause her death. Yeah, it was a sad situation. All right, another one that's caused by strep is rheumatic fever. So rheumatic fever is one that the strep infection can spread throughout the body, and it causes specifically heart damage. It causes vasculitis and damage in the valves, but it can also spread to the joints and the skin and the brain and cause other systemic issues for a patient, which is why, again, in that 5 to 15-year-old range, we need to treat strep throat strep infections with antibiotics pretty rapidly. So this diagnosis, Jones criteria, is what we use to diagnose this. It's a classification system that we look at minor and major symptoms. I don't expect you to have all of those memorized. Just know the name Jones criteria. And those are things like carditis, which is that friction rub, the murmur, and the rub that happens because of that inflammation in the heart. Polyarthritic pain, so their joints start to hurt. They get chorea, which are those abnormal body movements, irregular body twitchings. Subacute nodules, which feel like little nodes underneath the skin. They kind of feel like lymph nodes, but not in places that you would find lymph nodes. Fever and rash. Scarlet fever is strep throat that they get that rash from. So if you ever heard that term scarlet fever, it's like strep throat, except they have a rash on top of that. So treatment for this is going to be treating the strep infection. with antibiotics, usually a 2-week course of antibiotics, and then treating any of those cardiac issues. So specifically the valve damage that happens, replacing the valves is oftentimes something that's needed. Unfortunately, children that develop rheumatic fever, this is something that has to be monitored for the rest of their life because it will cause problems down the road as they head into adulthood. They don't always need the valve replacement when they're kids. Sometimes it's later on as an adult. Once this is developed, it's kind of a lifelong problem. Pediatric hypertension. So primary is no known cause. That is linked to things like obesity. That's a risk factor. Genetics and environmental factors are part of that are linked to primary obesity. Secondary is when we have an identifiable cause, like the patient that has heart disease or kidney disease, or an endocrine disorder that can cause hypertension, a secondary cause of hypertension. Blood pressure issues are not something that we normally see in kids, but because of our obesity increases in the United States, we are seeing a lot more cases of primary hypertension in pediatric patients than we used to. Basically, we do BP screenings on kids once they hit at least 3 in the doctor's office. The normal checkups that we do every year with kids, once they hit 3, we do a blood pressure screen. Younger kids, it's not something we normally check. That's outside of acute care settings, right? If you're in the hospital, you're doing blood pressure checks on your patient. This is just normal pediatric checkups. We want to make sure if they have hypertension that we're ruling out any underlying cardiac or renal issues or those kind of things. And if it's secondary hypertension, treating those underlying issues. If it's primary, a lot of times it's just diet and exercise, just like we do with our adult patients. It's things like the DASH diet and lifestyle changes, like getting them up and exercising more frequently. We have compliance issues with medications, just like we do with adults. They have all the same side effects. Beta blockers are one of the most commonly used medications. They don't come with a lot of side effects, and they are generally well tolerated, but they do have things like fatigue. They can make kids a little bit sleepier. It's not uncommon to see things like dizziness when they get up when they're on those medications, so they don't always take their meds as they should. And hypertension is a silent disorder, right? Sometimes patients don't have any outward signs that they have hypertension, so they're like, oh, I took my meds for a month, I must be cured, and they stop taking them. So we want to make sure that they're educated about reasons behind that and that it can cause long-term impacts on their heart function if they have hypertension for a long time. Kawasaki's disease. So I love the name on this one. Dr. Kawasaki is the man that named this. He is a very small Japanese man that I got to meet when I was working in San Diego because it's a Kawasaki's treatment facility, and he came to give a talk while I was there. So it's kind of cool to get to meet the person that behind the name of some of these disorders that you get to work with. So this is a disorder that causes a systemic vasculitis, inflammation in the vessels throughout the body, and it specifically attacks the heart vessels. The coronary arteries are specifically attacked with this one. It is idiopathic. We don't really know why kids get this, but it's very common that we see it post-viral infection. I mentioned this one last week when we were talking about coronavirus, that we're seeing this Kawasaki's-like disorder with patients that have COVID. Yep, so coronavirus patients seeing this. Yeah, they have a different name for it. It's not Kawasaki's, but we're not quite sure if it causes cardiac symptoms specifically, but we're seeing the vasculitis kind of symptoms throughout the body systemically. Because it's so new, we don't actually know what long-term impact will be. Yes, what is it called? Pediatric multi-system inflammatory syndrome. Multi-system inflammatory syndrome is what they're calling it. Really long name. Yep. PMIS, yeah. But similar to Kawasaki's. What they were finding initially was the kids were getting this rash, and that's what we see with Kawasaki's patients, is this rash that develops. So we have coronary arteries that get inflammation and aneurysms specifically. That puts this patient at risk of a heart attack. Hearts are not something that we normally see in pediatric patients. It's not like a normal thing that we see unless there's an underlying disease that puts them at risk, like Kawasaki's. So these are the signs and symptoms that we see with Kawasaki's. High fevers for more than 5 days. So this is usually 104, 105 fever for more than 5 days. Strawberry tongue. They get pink eyes or conjunctivitis, which looks like this, except they don't have the drainage that we see with kids that have like bacterial conjunctivitis. It's just the redness that they get. Red hands and feet, so the palms of their hands and the soles of their feet become red and start to peel and crack. And that's what we've been seeing with the COVID issues. Arthritic pain throughout their body. They get joints that start to ache and hurt. So that's the acute phase. The subacute phase is the coronary artery damage that's happening, that vascular inflammation that's happening. And then our convalescent phase is going to be when the lab values return to normal and all of their symptoms go away. That can take 1 to 2 years in a lot of cases for this to happen. It's mainly only seen in kids under the age of 5. So this is usually only younger kids that we're seeing this in. And we see it higher in our Japanese American population. All right, so treatment for this. This is what that rash looks like that I was talking about. And these are the lips and the mouth and that conjunctiva. So treatment, aspirin, high dose aspirin. Yes, I said aspirin. Normally, we do not give aspirin to children. I don't want you normally to give aspirin to children. The benefits outweigh the risks with giving aspirin to children with Kawasaki's. This is high dose, usually the 325 milligram aspirin. It's not a baby aspirin. It's a high dose aspirin therapy. Now think about why you give aspirin to your heart attack patients, right? You remember Mona, morphine, oxygen, nitric oxide, nitroglycerin, and oxygen, right? Or aspirin. So aspirin specifically affects those coronary arteries and reduces that inflammation on that area of the body. So that's why we give aspirin for this patient. It's more effective than giving them ibuprofen, specifically because of that impact on the heart. Yes, there is an increased risk for clotting issues, a risk for bleeding. So it's cautiously administered, and we have to carefully screen. We have to be very, very cautious about looking for other signs and symptoms. They should not be given ibuprofen when they're on this high-dose aspirin therapy. There is a very minor concern for Reye syndrome. That's why the benefits outweigh the risks. Yep. And really, Reye syndrome, we only see present mainly when a kid gets sick with a viral illness at the same time as taking aspirin, like they get the flu at the same time as taking aspirin. That's what causes that to happen. And we'll talk about that one next week, actually. That one's in the cerebral dysfunction chapter. So high-dose aspirin, acetaminophen is for those arthritic pains that they get throughout their body. IVIG to help reduce and deal with this autoimmune inflammatory response that's going on in the body. Mouth care because of this, right? They get this peeling, cracking mouth, lips here, so that's important. And then cardiac management. So if they have aneurysms, especially if they have large aneurysms, a lot of times they'll be on strict bed rest. We don't want to put any strain on the heart. They'll be on a full Sierra monitor. They'll be in the hospital on strict precautions. With mild symptoms, because not every kid will get an aneurysm or get severe cardiac symptoms. With mild cases, they may be at home with management and treatment. And as they recover, they'll go home and have a little bit more management at home. So strict precautions with the cardiac stuff. And again, it could be a 1 to 2 year period it takes them for recovery for this disorder. Pediatric dyslipidemia, so high lipid levels, those LDL, HDL levels are checked at a general screening times twice during pediatric years at the 9 to 11-year-old range, and then 17 to 21-year-old range. We generally do a screening. This is rare to see in kids, but we are starting to see this more frequently because of things like obesity increases in our peds patients. Treatment. Diet and exercise. The medications that we use, like the statins, should only be used once they're older than 10 years of age. So diet and exercise are the main treatments for this patient. Mediterranean diet is one of the ones that we generally recommend, and just getting out and exercising. I remember with little kids, that's playing, getting them outside and playing more frequently, like going out and playing soccer or something like that is exercise for a peds patient. All right, you made it to the post-test with cardiac stuff. Parents of an infant with tetralogy of flow are asking the nurse which defects are involved. Select all that apply. So put on your response there which numbers do you think it is. So VSD, right ventricular hypertrophy, left ventricular hypertrophy, pulmonary artery stenosis, overriding aorta, or PDA. So select all. Good. So VSD, yes. Right ventricular hypertrophy, yes. Pulmonary artery stenosis, yes. Overriding aorta. So 1, 2, 5, 6. Nurse is caring for a 3-year-old whose caregiver noticed that the eyes are red with no discharge, the palms and soles are red, swollen, and peeling. Upon exam, the nurse's assessment includes dry, cracked lips and a strawberry tongue. The nurse suspects what? Kawasaki's, not the motorcycle, the disorder. An infant with congestive heart failure is receiving DITCH to enhance myocardial function. What should you assess prior to giving the med? Yellow sclera, apical pulse, cough, or liver function? Apical pulse, yeah, 2 on that one. What should be the rate for an infant? Good. Yep. 90 a minute. Good. In which of the following congenital heart defects would the nurse need to take upper and lower extremity blood pressures? Transposition of the great vessels, aortic stenosis, coarctation of the aorta, or tetralogy of Flow? Good. Coarctation of the aorta. Now remember, that's one that will cause lower blood pressures in the legs. Normally our legs have slightly higher pressures than our arms do. This patient would have lower perfusion to those lower extremities. And then here's Juniper when she was 3. 3. So this picture here, this big blue box there was her Berlin heart. That was what was doing the workload of her heart. That was literally what was pumping her heart. You can see this sticking out of her chest, right? In the video, you can see that it was pulsating, right? That was what was doing her heart work. She's doing really well now. She's almost 6, or she's 6 and a half, 6 and like 3/4. Finishing up kindergarten. She is now mostly eating on her own. So she last winter was doing really well with eating on her own. She got sick with RSV and kind of backslid a little bit, but now she's mainly eating foods on her own, and she's done really well. She's got 2 younger siblings now who don't have any cardiac issues and is doing well in life. So yeah, if you've seen any of these billboards around town, that was Juniper. So she's been a big sponsor with Children's, and her mom's been on the news a couple of times for supporting organ donation. This is, if you guys want to look at these links, I put a couple other links in here. This was her 1-year video that they did, and then at 3 years, 9 News did a video update on her, mainly for like organ donation. So, all right. That is the end of the cardiac section. So let's take another break there. It's 4:45 now. So let's come back at 4:55, and then we'll do our hematology chapter. All right, guys, I'm back. This one slideshow. Thanks for asking. Yes, she is. She was pulling out her easel, which is like a big, like an easel like this that goes on the table, and it's a big wooden kind of thing, and she was pulling it out and dropped it on her foot, which was why she was screaming. Doesn't look broken. She definitely has a little bit of a bruise there. But yeah, I was right above my head in because my office is in the basement, so she was right above my head when it happened upstairs. But she's back to running around playing. Kids will do that. All right, our last chapter here is chapter 24. We're doing hematology and immune dysfunction. So a lot of this is going to be stuff that you've been familiar with from other chapters and med-surg. So we're going to go through this. I know we've only got an hour left for this content, so we're almost done for the day, guys. The cardiac is what takes the most amount of time this week. So heme dysfunction. Right, CBC. Getting a CBC on a patient and figuring out their blood count is an important part of your heme function assessment. There are some differences with lab levels with our pediatric patients in terms of like their hemoglobin levels, especially between premature babies and infants. I do not expect you to know those differences. What I do expect you to know is what a normal CBC count is for adult patients. So normal white blood cell count, normal red blood cell count, platelet counts for adults based on what you learned in med-surg. So keep that in mind. If you're working at a pediatric facility and you're looking at that, you're going to get a range for whatever that facility's ranges are. But no, there are some differences with infants and older kids. So history and physical assessment. So your signs and symptoms of heme dysfunction. Things like a child that has more fatigue than usual. That child's energy level is an important part of that. The parents are a great resource to figure this out from. Ask the parents, what is the normal energy level? Are they all of a sudden taking more naps than usual? You know, this could be a kid that all of a sudden is taking naps when they never took naps before. Their bruising risk. Do they have petechiae or purpura or more bruises than usual? Are they getting more infections than usual? More fevers? I'm trying to think of eating habits is something that is also something that we would want to think about with a patient that has heme dysfunction. Bleeding episodes would be another thing that we're thinking about. So getting those complete signs and symptoms of what we might be seeing if a patient's having dysfunction with their CBCs, those hemoglobins, those white blood cells, those platelet counts. Growth pattern issues are also another common thing that we see with heme dysfunction. Usually we see growth failure with kids that have heme dysfunction. Here's an interesting fact about our heme system with our peds patients. So in young kids, and infants and young kids specifically, all of our bones contain red marrow, which basically means that it's still producing cells. It produces red blood cells, white blood cells, those kind of things. Once we head into adolescence and our bones stop and fuse, we are no longer producing those cells in all of our bones. It's only produced in certain parts of our body still. We have the ribs, the sternum, the vertebrae, and the pelvis are still areas that are going to have those red blood cells produced. The patient that gets a bone marrow biopsy, that's usually from that iliac crest on the hip, that's because that area is part of the body that still has red blood cell producing marrow. So those younger kids need all of that healthy bone marrow to help produce all of those cells. So CBC count is an important part of that assessment. Hemoglobin, what's the big thing with hemoglobin? What does it do? Yeah, it's oxygen carrying capacity, right? So if we have low hemoglobin counts, we're going to have decreased perfusion to the rest of our body. Reticulocyte count is an important thing that we're looking at in terms of red blood cells. Remember, reticulocyte count is an immature red blood cell. So if that count is low, that may indicate something like that bone marrow that's not working. So that could be seen with the kid that has leukemia. We would see a low reticulocyte count because that bone marrow is not working anymore. In a patient that has a high reticulocyte count, that could indicate things like bleeding episodes, the kid that has bleeding going on, or potentially Something like sickle cell anemia, when they have a lot of sickled cells, the body's going to try to make more of those red blood cells to try to accommodate for that, compensate for that. And so we may see a high reticulocyte count in a sickle cell patient that's not doing well. All right, white blood cell counts, those are usually indicated high with infections, but we can see that also with things that cause inflammation in the body. So the kid that maybe has a chronic allergic reaction to something or is having really high allergies may have high eosinophils. A patient that's having more of a bacterial infection may have more of those neutrophils going on. So the differential is a really important part of the WBC, that white blood cell count, not just whether it's high, but what types of white blood cells are high, can help us figure out what's going on. Bands, remember bands are those immature white blood cells. So if those are high, the body's trying to compensate for something, coming up with something. But those bands, usually those immature white blood cells don't usually do a lot for the body. They can clog up the system. And we see that especially with things like leukemia. They can cause more harm than good. Platelet count. Platelet count, normal or not, a low platelet count can increase their risk of bleeding. If they have a low count, they can't clot. And if it's very high, they might be clotting too much. This is a normal blood smear slide. You can see a couple white blood cells in here. So these big blotchy ones are those white blood cells. The rest are red blood cells. And those are what normal healthy red blood cells look like on a slide. They're usually a pretty dark color. They're usually pretty solid in the middle. The composition of our blood, we have that plasma that's in there, we have the red blood cells in there, we have those white blood cells, and these bigger molecules here are those white blood cells. The blood, when it gets sent down to the lab, when you draw some blood and you send it down to the lab and you ask them for a CBC. Most of the time we're doing that with a computer system nowadays. We have a machine that we put the blood into, and the machine basically causes electricity to run through that blood, and it will bounce off of the different cell sizes differently, and that's how we can tell that we have, this many neutrophils or eosinophils because of that electrical conduction through there. If you send blood down to the blood bank or the lab and you say, I need a manual differential, that means you're asking somebody to sit with a slide and a smear and stare at that slide and manually count it out. So keep that in mind the next time you ask for manual differential. That's what they're doing. And I've done that many times overseas when we didn't have computers accessible. We had to stare at a slide and literally like, okay, that's a lymphocyte 1 and count it out. It gets tedious. Okay, anemia. So anemia is the most common hematologic disorder of childhood, and there's a lot of different types of anemia that we see. They basically will have decreased oxygen carrying capacity of the blood when they are anemic. There's a lot of different morphologies behind the anemia. If you think back to patho, you talked about a lot of these different pathophys reasons that we see this. So we can tell that by doing a lab sample and figuring out what type of anemia the patient has. Classifications of symptoms kind of go over whether it's something that's causing decreased production, and that's usually coming from things like the bone marrow not working, or the increased loss, which is usually things like bleeding episodes, or increased red blood cell destruction, which these are things like disorders that may cause this, like sickle cell anemia, or something like chemotherapy that we're giving that's destroying those red blood cells intentionally because of the underlying disease process. The most common type of anemia that we see with PEDS patients, it says the iron deficiency or these nutritional deficiencies. That's kind of the most common across the board. And when we have decreased production, that bone marrow is not working very well, we see a lot of those signs and symptoms that we talked about with a patient that has altered cardiac function, altered perfusion to the body, right? They're tired, their heart rate's elevated, they may have a headache, shortness of breath, muscle weakness, they may have a murmur. We also see pica commonly with patients that have decreased production. It's because their body kind of recognizes that there's some sort of low production, and they, a lot of times, especially with the nutritional deficiencies, they are trying to compensate, and they'll eat things that they shouldn't be eating. With the increased loss, we see a lot of those symptoms that we just talked about with decreased production, but we also see things like low blood pressure, because usually this is a volume issue. Things like DIC, ITP, or like, you know, a gunshot wound. That would be something we would see with that. Increased destruction, the couple that are a little bit different on that are the splenomegaly and the hepatomegaly. Remember that your spleen is processing all those dead blood cells, as well as the kidneys, so those will start to accumulate in those areas when we have increased destruction. One of the other things with kids, especially with infants, is this frontal bossing that can develop. The best way I can describe what frontal bossing is it's kind of like if you've ever seen a picture of a caveman, you know, they have big foreheads. That's kind of what frontal bossing is, and you'll see that with chronic destruction with younger kids, that's something that can develop. All right, either way, whatever the underlying issue is with anemia, they have decreased oxygen carrying capacity, which means there's decreased oxygen perfusion to our tissues. Effects on the circulatory system, we will try to compensate, and kids are actually much better at compensating for anemia than adults are. They will hemodilate and they will increase their heart rate. So that heart rate goes up pretty effectively, that increased heart rate. Kids are just better at doing this. Their hearts are healthy muscles, and they usually are able to compensate a little bit more easily. So one of the things that we see is the cyanosis is not typical with these kids because they can compensate by keeping that heart rate up. However, that increased cardiac circulation puts them at greater risk of things like a murmur and cardiac failure because it's just too much workload on the heart. The murmur is usually because of that increased flow. A flow murmur. It's because of that faster circulatory system happening, and it causes a murmur sometimes. Growth failure is common with kids with anemia. They have failure to thrive, and they also usually have delayed sexual maturation. So if they're in puberty, puberty is usually a little bit delayed. Diagnosis of this, typically if their hemoglobin is less than 10 or 11, but a lot of times we also look symptomatic hemoglobin levels. So if they're doing okay at 10 or 11 and they're symptomatic at 9, maybe that's when we diagnose it. But typically 10 or 11 is what we're looking at for a low hemoglobin level. Treating the underlying cause is important with anemia because there is slight differences with what the cause is. If the bone marrow is not working, or not producing enough, it's not going to be the same treatment as a patient that's bleeding out. So fixing what the underlying issue is, nutritional interventions are really common across the board to help the body produce more, like the iron that we talked about. Supportive management is good across the board, but it doesn't necessarily help the underlying issue. We may give IV fluids to help with volume, but that's not going to help my oxygen carrying capacity, right? A patient that has low blood pressure, I'm giving saline to may help increase my blood pressure, but it's not going to help the amount of oxygen available to those tissues. Oxygen may help. We give oxygen, makes it more readily available. However, if I don't have enough hemoglobin to transport it around the body, I'm still going to have decreased perfusion. Bed rest, just like with the cardiac patients, if they have trouble getting good perfusion to the rest of the body and they are exercising or they're playing or they're feeding, that's putting extra workload on that heart and extra demand on the body and could lead to decreased perfusion. So we want to make them rest as much as possible. Diet interventions, things like the leafy greens, red meat, and dietary supplements are necessary sometimes to help improve that production. And then family education. What is the underlying issue with the anemia? What has caused it? What is the treatment for it? And things like frequent lab tests. Kids that have chronic anemia, such as sickle cell anemia, have lab tests all the time that they have to go through. So when we talk about preparation, age-appropriate preparation for testing, things like reward systems for the kids that have to come in and get frequent finger sticks or lab draws can be helpful for that. Decreasing those oxygen demands and preventing complications, like keeping them from getting sick, because a respiratory illness on a kid that's anemic can be pretty deadly. So we want to make sure we're preventing some of those complications. Let them rest, decrease stress to the body, and then supporting the family. Things like sickle cell anemia are genetic, so we want to make sure that we're thinking about those implications for passing that on or having another child that may have the same disorder that they're dealing with as the one child. So we're going to talk about a couple forms of anemia. Iron deficiency anemia, we're going to talk about sickle cell anemia. I don't go through beta thalassemia. That's one that you guys talked about in med-surg. And then aplastic anemia we're going to talk about. So iron deficiency anemia, this is usually a dietary deficiency. We see this at predictable periods for children, premature infants, and infants in general we see this with. Think back to a few weeks ago when I talked about hemoglobin function with infants. What age do they lose mom's red blood cells? What age, around what age do we see that loss? This was week 2 we talked about this, so we're pulling out some old information. About 3 months. It's usually closer to 4 months. So between 3 to 6 months of age is when we see that. They've lost mom's red blood cells and they have to make their own. So their bone marrow has to catch up. So it's really important for them to have enough iron in their diet to make those red blood cells. So during that premature period or those infant periods, we see this pretty fairly common for them to be anemic during that time period, especially around that like 6-month period. They haven't quite caught back up, but they've lost all the mom's red blood cells. Most infants that are breastfed are not getting quite enough in the breast milk, so sometimes they need supplements if they're anemic. If they're taking formula, usually they're getting it in the formula. Toddlers and adolescents, usually because they're just not getting enough in the diet. This is what a anemic red blood cell looks like. So it may be there in the body, but it can't attach to oxygen and it doesn't have much good. It kind of clogs up the body. And these, if you compared it to another slide with healthy red blood cells, they're a little bit hollow in the middle, a little bit paler than they are compared to a healthy red blood cell. Signs and symptoms of iron deficiency anemia: pale, irritability, tachycardia, fatigue, the glossitis, especially with chronic anemia, and the spoon nails, that's with chronic anemia. Management for this patient: infants and kids, slightly different. With older kids, it's really hard to get enough dietary change to actually improve their anemia. So a lot of times they need supplements. With infants, it may be something like switching them up to an iron fortified formula. But most of the time, kids, especially in that acute period, will need supplements. And this could be a pill or liquid. And we have a liquid here that's a little dropper that we'll give with infants and toddlers that can't swallow pills. It should be given with between meals. Giving it with food can block the absorption of it, so better on an empty stomach. However, a lot of kids do get nausea and vomiting with it if given on an empty stomach. So if they are getting sick with administration on an empty stomach, give it with a snack. But the snack should not be anything that's dairy related. So don't give it with milk, don't give it with cheese or yogurt, those kind of things. Juices, like a citrus juice, is great. So if a kid needs a snack, give them an orange, let them eat the orange, and then give them their iron supplement. That's actually really helpful because it'll improve the absorption rate. It does turn their stools a tarry greenish blackish color. And if you don't tell mom or dad that that's going to happen and they go home, they see this tarry greenish blackish stool that the kid has, they're going to freak out because they're going to Google it and they're going to think their kid has a GI bleed. Tell them about it ahead of time. It also really commonly causes constipation. So just like we've talked about constipation in class, make sure you give them some helpful tips on how to deal with constipation at home. Using a straw or syringe is helpful because it does stay in the teeth if it's left on there, so letting them drink something afterwards is useful. And then other supplementation that could be used, things like the baby cereals or Kellogg's cereals, those usually have extra iron fortification in them. So getting more of those food supplements in is also really helpful. All right, sickle cell anemia. This is a hereditary disorder. It is an autosomal recessive trait, just like when we talked about sickle cell anemia or cystic fibrosis. It is a 1 in 4 chance per pregnancy if both parents are carriers of the disorder. We mainly only see this in African Americans, or Africans. Basically our Black population are the highest population that we see this with. Because it started in countries that had high rates of malaria, patients with sickle cell disease did not get sick with malaria. It was a protective means for them. However, we can treat most malarias now, but sickle cell has gone away in the population. So we do see this mainly in that population. And it does show up in some other ethnic groups. I've got a couple examples here: Mediterranean, South American, Arabian, and East Indian. I've seen it in a few Hispanic populations in the United States, but that's the rarity. It's extremely rare to see in a Caucasian patient. The incidence is about 1 in 375 children born in the U.S. to African-American parents, and the carrier rate is about 1 in 12 are carriers of the sickle cell trait. So again, autosomal recessive trait, 1 in 4 chance per pregnancy of having a child with the disease. with the presentation of the disease. And this is basically what's happening. Instead of those normal healthy red blood cells, we get the sickled C shape that causes all the symptoms. Those C shapes kind of stick together and they hook on each other, and they can cause blockages, decreased perfusion, and damage to the vessels throughout the body, anywhere in the body. This is what it looks like on slide. These little shapes here, those little C shapes there. You can imagine those kind of getting clumped up and blocking up the body. The diagnosis of this, we do test for this in all 50 states in the US now. That Guthrie heel stick test that I talked about is one that is what we will use for this. So that's the newborn screening. We can do testing on an older infant if we think that they may have it, like if they moved here from somewhere else, but they do need to be older than 6 months of age just because they have mom's red blood cells when they're younger, so they need to be older than 6. The sickle cell turbidity test basically causes those cells to sickle if they have it, and that's one way we can test for it. But we can always do genetic testing with an older child as well. So management goals. This should sound familiar from med-surg. So we want to prevent sickling from happening, and we want to treat those medical emergencies immediately. So treatment management for this patient. Analgesics for pain are really important. They have pain crises where they have pain anywhere in the body depending on where the clumping of those cells is happening. I have seen everything from mild management, from Tylenol, all the way up to PCA pumps and narcotics administered for patients with sickle cell anemia. PEDS patients, it's cautious administration with our narcotics. We do see narcotic addictions, and that can be at very young ages for kids that have been getting narcotics for their life for this disease. I've had kids commit suicide. I've had kids overdose as teenagers because of those chronic narcotic medications that they've been getting lifelong. So we want to manage their pain. We want to make sure they're comfortable, but we don't want to over-prescribe those narcotic medications. And think back to that pain chapter when we talked about other ways of dealing with their pain, you know, figuring out what is a good day and a bad day to help them with pain management. Rest is important. Anemia, decreased perfusion in the rest of the body. If they're anemic and they're going out and exercising and running and doing those things, they're putting more stress on the body, which can increase the risk of complications. Hydration is really important. Dehydration can cause sickling episodes, so they need to be hydrated. And then when they do have sickled episodes and they have crisis episodes, they need extra hydration to prevent further sickling from happening. Dehydration can be deadly for these kids, so hydration, hydration, hydration. Antibiotics. Any patient with sickle cell anemia needs to report a fever immediately to their primary care physician or whoever's made their care. Any sign of a fever needs to be reported immediately. And it's very common with kids with high-risk anemia or sickle cell anemia to take a daily low-dose penicillin. So Pen-BK is a very common one that you'll see used for these kids. They take a daily low dose to help prevent complications. And any sign of infection needs to be treated immediately with IV antibiotics. Hydroxyurea. This is a medication that's been used for probably around a decade now. We use this with patients with sickle cell anemia, and it works in a couple ways. It helps with increasing their fetal hemoglobin. Fetal hemoglobin doesn't sickle, so they have higher levels of fetal hemoglobin circulating through their body that won't sickle but can still give them oxygen perfusion. It also makes the red blood cells a little less sticky, so they're less likely to clump together and cause those complications from happening. So that's hydroxyurea, and it's a daily oral medication that they take. Let's see, could the daily penicillins, there is a risk factor with resistance. It's the same thing with like the kids with kidney issues that are taking low dose penicillin. It can lead to some resistance, but the benefits outweigh the risks with that one. Blood transfusions. So if they're anemic, we give them blood transfusions. We used to do exchange transfusions with these kids, especially with the higher risk sickle cell anemic patients. They would come in every month. We would take out a pint of blood and we would give them a pint of blood from somebody that didn't have sickle cell so that they had less red blood cells to potentially sickle and less risk of complications. But there's a lot of risk factors that go in with getting frequent blood transfusions, so we try to limit that as much as possible. And since hydroxyurea has become more of a permanent management for kids with sickle cell, we don't have to do the blood transfusions as frequently, which has been a positive. All right, bone marrow transplants. You guys talked about this back in mid-surge 1, so it's been a little while. Remember they're talking about different types of bone marrow transplants? Does anybody remember what kind of transplant this might be if we're giving it to a patient with sickle cell anemia? Take a guess if you don't know what it is. Okay, if you don't know, living donor, yes. So it is an allogenic, and we'll talk more about this in cancer next week, but it's an allogenic donor. So it's an allogenic transplant, not an autologous. So it's not from their own bone marrow. It's from a histocompatible donor. So, you know, same blood type, same histocompatibility, allogenic. We can actually cure sickle cell anemia with allogenic bone marrow transplants. And we've been doing this for a good 5 years now. It is done at most major children's facilities around the country. Children's Hospital here has done several successful bone marrow transplants on patients with sickle cell anemia. And it's mainly only used for a high-risk sickle cell population because there are a lot of risks with doing a bone marrow transplant. Because if it fails, the only recovery from there is another transplant. So it's not a free procedure, but we can actually cure sickle cell anemia with it. Because basically they get that bone marrow transplant, and that transplanted DNA from that new bone marrow will start to produce red blood cells and stop making the sickled cells anymore. So we can actually cure it, which is crazy, right? That we can cure a genetic disorder with something like that. All right, cell clumping. This is what happens. We get this obstruction of vaso-occlusion that happens anywhere in the body. The pain is from that vaso-occlusion that happens, and it can happen more frequently in like the little vessels of the hands and the feet, but it can also happen in those long bones throughout the body. Complications that sickle cell anemic patients get: risk for infection, risk for stroke, risk for respiratory issues, leg ulcers, and splenomegaly are complications that can happen. Now, across the board, one thing to think about and remember with treatment with sickle cell crisis is hop to it: hydration, oxygenation, and pain management. Now, hydration and oxygenation are only going to prevent further complications. They don't treat the underlying issue. Pain management is going to help treat the underlying issue, right, of helping treat that pain. So if you were given a prioritization question on this, pain management may be your priority. All right, different types of crisis, what precipitates it? Trauma, infections, low oxygen levels, which is why patients with sickle cell don't do great in Florida. Hypoxia is also something, you know, that if they go up to hike up in the mountains or something like that, that low oxygen level can do that. Dehydration, like we talked about, can do it, and stress, just stress on the body. The most common type of a crisis is a vaso-occlusive crisis, where they get cell clumping and they get vaso-occlusion or decreased perfusion to that area. It is painful, and it's a lot of times called a pain crisis. So they get pain wherever in the body we get that vaso-occlusion happening. They may have tissue engorgement, redness, inflammation, hot to the touch over that area that's impacted, but it kind of depends on the body. Sometimes it's the abdomen that this happens in, and a lot of times you won't see the swelling or the redness in that area just because you've got a lot of fat and those kind of things in that area. But if it's on a hand, you'll see more outward symptoms. They also usually have a fever because there's going to be some inflammatory process that's happening here to try to break up that blood clot. So what is management for this? Hydration, oxygenation, pain management, and sometimes we'll give medications to break up those clots depending on where it is. Splenic sequestration is another complication that happens. This is a life-threatening disorder. The spleen processes your entire amount of blood throughout your body within a few minutes. All of your blood, literally all of your blood through your body goes through the spleen that rapidly. So when they have splenic sequestration, basically they get blockage in the spleen, and all of the blood is going to be filtered into the spleen, but it's not going to filter back out. So your patient is going to have splenomegaly, and they can become hypovolemic and go into hypovolemic shock extremely rapidly, like less than an hour. So this can cause shock and death very rapidly for patients with sickle cell anemia, and it's hard to catch. So the treatment for this is a splenectomy. The prevention for this is a splenectomy. So the prevention and the treatment are the same thing, a splenectomy. Kids that have high-risk sickle cell anemia will take out the spleen to prevent this from happening because it is such a lethal complication. Aplastic crisis is when the bone marrow stops working. So all of those normal red blood cells, white blood cells are depleted. It is most commonly triggered by a viral infection. Parvovirus is actually one that can trigger this, or depletion of folic acid. So these kiddos take a daily folic acid supplement to help prevent this from happening. This causes profound anemia and pallor, signs of shock basically, and severely anemic. So management, hydration, oxygenation, pain management, and basically allowing that bone marrow to recover. So sometimes that's blood administration until that bone marrow recovers. And that's usually about a 1 or 2 week period before their bone marrow starts working again and they start producing cells again. Acute chest syndrome is another lethal disorder that can happen with patients with sickle cell, and it can happen very rapidly. It is very similar to pneumonia or a patient that gets atelectasis after some sort of episode where they're sitting for a long period of time and they get those symptoms. And you can see where the symptoms here: chest pain, fever, cough, tachypnea, wheezing, hypoxia. Sounds like a pneumonia, right? So very similar. They get pulmonary infiltrates because of sickling in the lungs. All of those little cells can sickle in the lungs and cause blockage, and perfusion decreases in the lungs. One of the most acute signs that you will see with this is a lot of times things like hypoxia that slowly develops. Think about the kid that's in the hospital with an acute pain crisis. They're not going to want to get up and move around because they hurt. They are at huge risk of getting acute chest syndrome. So we want to be very cautious and careful, watch these kids, have them on a pulse ox monitor, and if that pulse ox starts to drop a little bit, make sure you are notifying the provider. Because if you catch this early and start antibiotics and start extra fluids, those kind of things, it may help prevent it from going downhill. Cerebrovascular accidents or strokes. Kids do not get strokes. It's not something that we see like just happen like we see with our older adult population. It's really rare to see a stroke in a peds patient unless there's an underlying disease process. Sickle cell anemia is something that can cause a stroke because those sickled cells can block and cause a blockage in the brain just like they can anywhere else in the body. So the same symptoms we would see with a stroke in a peds patient, one-sided weakness, speech problems, one-sided facial drooping. Those are all things that we would see in a stroke patient that's a peds patient with us. I had a kid one time on a heme floor. I was in San Diego. Saturday morning, got a report, told that the patient had a pain crisis. It was a right-sided pain crisis, right upper extremity pain crisis, and he wasn't using the right arm. He wasn't wanting to use the right arm because it hurt. It's just common, right? It hurts, they don't want to use it. 5-year-old. So I go in and I'm doing my morning assessment on him, and I'm doing my head-to-toe assessment, and I get to hand grips. So I've got him go through his assessment, and I get to hand grips. I'm like, can you squeeze my hands? 5-year-olds can usually reliably follow those directions. So he grips it with his left hand, but he's not gripping it with his right hand. And I'd gotten a report that he wasn't wanting to do anything with that right side because it was hurting. I was like, okay, fair enough. I need you to try as hard as you can. I know it hurts, but I need you to do it. And he's still not doing it. So I asked him what his pain level was. He'd just gotten some pain medicine, and he tells me it's a 0. So I'm like, okay, there's no reason that you shouldn't be able to do this for me. I really need you to do this for me. So he's doing it with the left hand. He's still not doing it with the right side. So my brain immediately was like, I don't think this is just a pain crisis going on. I think something else is happening here. I think he might have had a stroke. So I go out. I called the resident. The resident had admitted him on a Friday night. Attending still hadn't seen him yet because it was a weekend. So the resident was like, I saw him last night. That's what he was doing. It's a pain crisis. I'm not there. I can't come up and see him right now. I'll be there later this afternoon. And so I argued with him a little bit and was like, I don't think he can wait. I think you need to come up and see him. And I still got a no. So I went over his head. I called the attending, and the attending listened to my story and immediately came up to assess the child. And sure enough, ended up sending him for a scan, and we found out he'd had a minor stroke. So he ended up in the ICU, and he got TPA to break up the clot, and he didn't have any long-term complications. With kids especially, it's really important to rely on your assessment skills. When you think that it may be developmentally appropriate for a kid not to follow directions, it may be something else going on. So when we talk about those like nursing sense, that like sixth sense that happens, rely on those kind of things, and don't be afraid to speak up. If you're not getting an answer and you're concerned about a patient's assessment, don't be afraid to call an attending if you aren't getting the answer that you think is appropriate for your patient, because who knows how long that kid could have sat there and waited and maybe had long-term deficits from that. And kids, they just, they don't always verbalize what's going on, so he may not have been able to verbalize that something else was going on. Makes it a little harder. Aplastic anemia, this is also called pancytopenia. So this is all blood-formed elements of the bone marrow have stopped being produced. So no white blood cells, no platelets, no red blood cells. All of those elements have been diminished. This is idiopathic in most cases. Kids develop this for unknown reasons. They're usually very healthy beforehand, and then all of a sudden this presents. So they have signs of, fever and bleeding and fatigue that they present with. Diagnosis, CBC and a bone marrow biopsy. On biopsy, the bone marrow basically has turned yellow fatty sludge. Instead of nice healthy red bone marrow, it is this basically fatty sludge that's going on inside the bone marrow. So it's not producing those cells like it should. Basic management or early treatment usually starts with immunosuppressive medications and immune modulators. If those don't work, then the last treatment method that we will go to is a bone marrow transplant. Bone marrow transplants don't always work, but if they do, then hopefully that patient's bone marrow will start working again and they will be just fine after there. I've taken care of quite a few of these kids on oncology because I was oncology certified for a while. So I've seen this on the medical side of things. I actually had a good friend of mine whose son ended up developing this, and he went through 2 bone marrow transplants before he recovered, and now he's like a year and a half, 2 years out now, and he's doing really well. And he was just asked to be one of the kid sponsors at Children's, because they have kids that have been treated at their facility that are like kind of spokespersons to help with peer engagement and that kind of stuff. And so it's pretty cool that he's been asked to do that now that he's recovered and doing better. All right, 14-year-old boy with sickle cell anemia is admitted with severe pain in his abdomen and his legs. He asked why the doctor ordered oxygen when he's not having problems breathing. The nurse will reply that the main benefit of oxygen is to prevent further sickling, prevent respiratory complications, increase oxygen carrying capacity of the red blood cells, or decrease the potential for infection during crisis. Yes, it's 1. So it prevents further sickling. If a red blood cell, that hemoglobin is attached to an oxygen molecule, it's less likely to sickle. The therapeutic management of children with sickle cell crisis consists primarily of which of the following: oxygen therapy, prevention and treatment of pain, adequate hydration, or frequent blood transfusions. We talked about. B, yep. All of those might be something that we use, where we may be doing oxygen, hydration, and blood transfusions, but B is that primary intervention. All right, the effects of homeostasis. So we're going to talk about hemophilia, ITP, and DIC. Hemophilia is another one that hopefully you guys remember from Med-Surg. I think Med-Surg 1 is when you talk about this one. So this is an X-linked recessive disorder. So we mainly only see males that present with the 2 main forms of this, but there is a form called von Willebrand that females can present with. But hemophilia A and B is only seen in males. Females are carriers. So hemophilia A, which is also called classic hemophilia, is a deficiency of factor 8. And it's about 80% of cases of hemophilia are factor 8 deficiency or hemophilia A. Hemophilia B is a little bit more rare. It's also called Christmas disease because Dr. Christmas is the person that named it. My brain always fills it in as Christmas tree disease. Nothing to do with Christmas trees, but my brain always says, oh yeah, Christmas tree disease, it's that one. Dr. Christmas named it, it's Christmas disease. Hemophilia B. That is factor 9 deficiency. And then von Willebrand is one that we see in males and females specifically. They are lacking von Willebrand factor and factor 8. So two of those pieces. And remember, both these factors are part of that clotting cascade. So if they're missing a piece of that clotting cascade, they can't clot. So the signs and symptoms that we see are bleeding, Mris. They don't usually present until the age of at least 6 months of age. Remember, they have mom's red blood cells before that point. But once they hit 6 months, it's all of their own red blood cells now. So we typically see things like bleeding, epistaxis, nosebleeds, they bruise easily, they're pale sometimes, they may have hematuria and hematomas. And then hemarthrosis are one of the big complications that happens. So they get bleeding into their joint spaces, and specifically like the knees are one of the more impacted joints because those are taking a lot of the weight and they take a lot of brunt of normal body movement. So they get these bleeding episodes into the joint spaces. The joint hurts, it's red, it's swollen, it's hot to the touch, and it can cause permanent inflammation and damage in that joint, where it causes arthritis and destruction of that joint. So this is a really important one that we need to manage when they have hemarthrosis episodes and prevent. So the big thing here is prevention with hemophilia, preventing those bleeding episodes. If I could bubble wrap these kids, I would. A 2-year-old is going to be a 2-year-old. So a 2-year-old boy especially, they're very active, and they're just going to run into things. They will do what 2-year-olds do, and they'll run into the side of the table or the coffee table, right? And they'll get a bleeding episode. They'll get a bruise and they'll start bleeding. We want to prevent that as much as possible. We want to keep them out of sports. Like, soccer is not a good activity for a kid that has hemophilia. So we want to prevent it as much as possible, but knowing that kids are going to be kids and they're still going to be playing, and increase risk with that. So because of that, we give replacing the missing clotting factors. If they have hemophilia A, we replace 8. If they have factor, or the hemophilia B, we replace factor 9. So it depends on which form they have and what we need to replace. So they're going to get regular infusions of whatever clotting factor they're missing. If they are having a bleeding episode, they need increased clotting factors to stop that bleeding. And so sometimes in the hospital, they'll get admitted for a couple days so that they can get several doses of that factor that they're missing. Parents are trained to give the factor at home, so it's definitely something that can be managed at home. It can be given IM. IV is also another form, especially in the hospital, we'll give it IV. So they need regular infusions of that clotting factor. Desmopressin is something that we use with mild hemophilia A, so only with mild hemophilia. It can actually make severe forms a little bit worse, so we only use it with mild hemophilia. It basically makes factor 8 a little bit more effective by 2 to 4 times. So that may be something that we give like as an extra dose in the hospital when they're sick or they have that bleeding episode. Transfusions may be needed, especially if they're anemic and they're having large bleeding episodes. Medications that are used are corticosteroids are the main one. And when they have cases of hemarthrosis, like you can see in this picture here, you see those knees are so swollen and inflamed. We want to reduce that inflammation to prevent that damage that's happening in the joint. So corticosteroids are used during that period. Exercise and physical therapy are really important for patients that have hemophilia, because if their muscles are stronger, that helps support those ligaments and the joints, so they're less likely to get hemarthrosis. So we want to keep them active. We don't want them to do sports that could hurt them, but things like swimming are great activities for kids that have hemarthrosis. And then rest. If they're having a hemarthrosis episode or they're having bleeding, rest, ice, compression, and elevation above the level of the heart. So lay them down, put that leg up, put the arm up, whatever it is, above the level of the heart. Immune thrombocytopenia. The old name for this was idiopathic thrombocytic purpura, or ITP, but mainly this has been renamed to immune thrombocytopenia, because we know in most cases with this is an autoimmune response. The kid gets sick with a recent viral infection of some sort, usually like a respiratory viral infection, and then the body for some reason has this autoimmune response where they destroy their platelets. So they have excessive destruction of their platelets. Nothing to do with the bone marrow. They still have healthy bone marrow. Bone marrow is still working, but the body is attacking those platelets and destroying it. And typically we see platelet counts of less than 20,000 with patients that have ITP. So less than 20,000. Normally, right, 150 to 400, 450. This is a kid that has a platelet count less than 20,000. So they're going to bruise. They're going to have petechiae, purpura, bruising. There is a form of chronic immune thrombocytopenia that's rare, but it can last for long term and it causes more complications. I had a kid that came in with this ER patient. She came with bruising and pallor and fatigue, and we'd drawn some labs, and I thought it was going to be a leukemia workup. helps the kid to the bathroom because she needed to go to the bathroom. So I help her into the bathroom. We get in there. She gets a nosebleed while we're in the bathroom. And I only had gloves on because I was just helping her to go pee. We get blood everywhere. It's all over her. It's all over me. It's all over the floor. It was like the most amount of blood I've ever seen come out of somebody's nose. Get her back into the trauma room. Get the bleed stopped. I got her lab levels back, and her platelet count was 7,000. Platelet count of 7,000. That's it. Barely any platelets. So super, super low. But you want to know what we did with her? PKI purpura. You know what we did with her? We sent her home. So this was mainly a self-limiting disease. So we gave a dose of anti-dimer. We've got that on the slide there. So anti-D-dimer. It's a one-time dose usually, and it causes a temporary bump in their platelet count. So it'll give them a little bit of boost up in their platelet counts. We give IVIG, helps support that immune system, right? We give prednisone to help suppress that autoimmune response that's happening. So this is usually oral prednisone, so oral high-dose prednisone. Activity restrictions. We basically tell them to plop themselves on the couch and don't move until their body starts to recover. And it usually takes a couple weeks. Their destruction will stop and their bone marrow will catch back up, basically, because they're still having production of that platelets, but they just need to stop the destruction that's happening. We do not give platelets to this patient because platelet administration will make it worse because their body's destroying the platelets. It'll just make it worse. So we don't usually give platelets to them. And sometimes we even tell them to put it on when they're in a car to the clinic, because if they get into a car accident in the clinic or in the car on the way to the clinic, it could cause a brain bleed to happen. In the severe cases, especially with the chronic form of this, which is harder to treat, a splenectomy is sometimes needed. DRC. All right, this is my 2-minute spiel on DSC, guys. I know you spent time on this in your ICU class, in your Med-Surg 2 class. DIC is a complication that can happen, and it can happen for a really wide range of disorders. I put some of the common causes up here. Sepsis is one of the most common causes in those patients. They get sick with an infection that could be bacterial or viral, and that triggers DIC to happen. Flu can trigger DIC. We're seeing DIC happen because of coronavirus right now. So any underlying issue that causes endothelial damage and inflammation in the body can cause those fibrin clots to form. And sometimes the body does this too much. So then we end up clotting and clotting and clotting. And we use up all of our clotting factors, and then we start to bleed. So we bleed and clot and bleed and clot and bleed and clot. Okay, does that make sense? That's 2-minute spiel on DIC. Bleeding and clotting is the big thing to remember with that one. And on the next slide here, I just put the actual pathophys of what's going on there. Now, one thing to keep in mind is this PTT and thrombin time that increases. You'll see that start to increase. That bleeding time is going to increase. Patients that have DIC and are in the ICU, or patients that are sick in the ICU, we frequently draw CBC levels on them to keep an eye on those lab levels. If you start to see that PTT slowly start to increase, this is something you should be thinking about. Treatment of DIC is very challenging, and really it's going back to the underlying issue. This is the complication that can happen once DIC develops. Loss of perfusion, and usually you see things like petechiae that will start to develop, especially in the peripheries, and it will progress to significant vascular compromise for your patient, necrosis. So treating DIC, treating the underlying cause. If it's sepsis, fix the sepsis. If it's viral, it's really hard to treat because we don't have medications that treat all the viruses, but treating those underlying issues. Sometimes we give platelets and fresh frozen plasma, but if we give platelets and the body's just using them up, sometimes that can make the symptoms worse. So it's very cautious administration of those blood products. Exchange transfusions are sometimes used with kids where we literally take out all of the unhealthy blood and we give them a whole new set of blood that has all those replaced clotting factors. And sometimes that kind of resets the system. IV administration of heparin is kind of a last-ditch effort. This is really used with the patient that we've tried everything else on. The heparin will keep them from clotting more, but then that is a huge risk for those bleeding episodes. So basic management with DIC, catch it early, treat the underlying cause to help prevent long-term complications. Okay, that was my like 2-minute spiel on DAC. I think it took me 3 minutes. So which of the following describes ITP, that immune thrombocytopenia? So in your chat window, put which letters you think are right. Select all, apply. ITP is a congenital hematologic disorder. ITP causes excessive destruction of platelets. Children with ITP have normal bone marrow. Platelets are normal in ITP, or purpura is observed in ITP. All right, I got 8 students participating. You guys all asleep or not paying attention? There we go, we got a few more. Okay. Thanks, guys. I know, it's a long day. I know. Hang in there, we're almost done. ITP is not a congenital disorder. Remember, it's an autoimmune, it's an idiopathic disorder. It does cause increased destruction of platelets. So B, they have normal bone marrow. They don't have normal platelet counts. And they have purpura petechiae. So B, C, and E on that one. Screen fatigue is real. I agree. We're almost done. Nurse is caring for a kid with von Willebrand's, so the nurse is aware of which clinical manifestations with von Willebrand's. So select will apply on this one too. Bleeding of the mucous membranes, child bruising easily, excessive menstruation, frequent nosebleeds, creatinine levels elevated, or factor IX deficiency. Okay, so remember von Willebrand's is hemophilia, and it's one that's present with girls and boys. So yes to bleeding of the mucous membranes, yes to them bruising easily, yes to excessive menstruation because it's present in girls too, and yes to those frequent nosebleeds. So bleeding anywhere in the body, something we see with hemophilia. Not related to creatinine levels. I haven't talked about creatinine at all today. The child with factor IX deficiency is not right. This is a factor VIII deficiency. So they're missing von Willebrand factor and factor VIII when they have von Willebrand disease. So ECD. Elementary school nurse is giving care to a hemophiliac who has significant pain to his knee. The nurse suspects hemorrhagosis. As the nurse waits for a family to pick up the child, the nurse would maintain joint mobility with passive range of motion, elevate the leg above the heart, administer children's aspirin or ibuprofen, or apply warm soaps to reduce swelling. Yep, elevate the leg above the level of the heart. So maintain joint mobility. We do not want to move them when they're having a hemorrhagosis. We want to mobilize a splint with like an ACE wrap or something like that. We don't want to give them aspirin, ibuprofen. That can increase the risk of bleeding. And warm soaps are not helpful. Ice is good to help vasoconstrict. I saw a question there about how do we manage excessive menstruation with the females. Giving them those factors and making sure that especially before their periods that those factors are in good levels in their body. So giving them the factor VIII replacement and giving them that von Willebrand factor can help manage that so that they don't have that excessive menstruation that happens. Does that answer your question? I think it was Isabel that I saw that and pushed that. Yeah. Awesome. All right, last couple disorders here, guys. HIV, severe combined immunodeficiency, and Wiskott-Aldrich. So HIV and AIDS. I'm not going to talk about the medical management with this. The big thing that we see with children, the main cause of transmission with children is perinatal transmission. So it's from mom to baby. Mom is positive, she passes it on to the child. And so that's the most common reason that we see HIV in children. We do see some of that vertical transmission, horizontal transmission with at-risk behaviors like sex and drug use with our teenagers mainly. but that's not the most common cause of it with our pediatric patients. We use antiretroviral medications with peds patients, the same medications that we use with adults. It's weight-based dosing. They're on triple therapies. It causes symptoms and side effects. It makes them nauseous. It doesn't make them feel great sometimes. So sometimes they don't want to take their meds. Sometimes it sucks to take them. One of the most common causes of death from this disorder is opportunistic infections. Respiratory, like pneumonias, are some of the most common causes of death from HIV and AIDS with children. Careful immunizations with kids that have HIV, because if they're immunocompromised, a live vaccine could cause them to get the disorder. So those are a couple management with the medical side of things, couple education things, so more the psychosocial side with kids to think about. Teens especially, the sexual transmitted factor there, we want them to know about it. We want them to make sure that they're cautiously using condoms and prevention of transmitting it to others. Heart therapy is what we use to prevent transmission from mom to baby. So highly active antiretroviral therapy. It's slightly different than what the normal protocols are when they're pregnant. If taken appropriately, this is upwards of a 98% effective at preventing transmission from mom to baby. So because of that, we test all pregnant mothers in the United States when they come in for prenatal care for HIV, so that we can put them on this medication to prevent transmission to baby, if taken appropriately. If mom wants to breastfeed, we will usually let mom breastfeed, but usually limited for the first couple months. Because there is a risk of transmission in the breast milk, we only limit that for the first couple months, and then otherwise they'll be put on formula. Stigma, school. You do not have to tell the school, teacher, or classmates that the child has HIV. This is a health protected information, and it can create stigma. It can create challenges with them fitting in and being accepted in school. There is social isolation that happens, stigma that still happens. This is a real book. My friend with AIDS is still my friends. The teachers are taught standard precautions. They're taught to put gloves on if the kid has any sort of bleeding, you know, they fall in the playground and cut themselves. Now, it will be on their chart in the school with the school nurse. It'll be on there, but we don't have to tell their individual teachers to help protect their identities so that they can live normal functioning lives. The other thing that's on here is telling the child, the psychological impact of telling the child that they are positive. Knowing that most of the pediatric cases are mother to child, meaning that they're positive from birth. What age is appropriate to tell the child? There's not a right answer on that. Every kid is a little different. Every family is a little different. Most of the kids that are younger, like the 4 to 5 year olds I know with it, can tell you what meds they're on. And if the family's open about it, they know why they're taking them. The older kids need to be told, especially by the time they usually hit at least school age, because kids do stupid things. You know, they do things like blood brothers. They'll do things like have sex, and they need to know so that they're preventing that transmission to somebody else. In pediatrics, though, one of the challenges that we have with pediatric management, with any disorder that may be lethal, like cancer or HIV, if the parents do not want to tell the child, we cannot legally tell the child. Parents are in charge of their medical management and their authority until they are 18 years of age. So if the patient is HIV positive and the parents do not want to tell them, you cannot tell them. Now, we will have a care conference and we'll sit the parents down and we'll talk to them about it and we'll discuss why it's important for their child to know. But that's still the parent's right until that child is 18 years of age, that we cannot tell that parent agrees to it. Yeah, it can be, especially by the time they get to be teenagers. And honestly, by the time they're that age, they're old enough to Google what med they're on and they'll figure it out themselves. But yeah, and I've had that happen with other disorders like cancer, where the parents don't want to tell the child that that's what they're sick with in the hospital. Single parent needs. A lot of times when we have kids that are positive, there's parents that are positive, so they may have lost a partner to the disease. They may be positive themselves and have their own, you know, huge medical management that has to be dealt with as well. So there's a lot of other psychosocial support that is needed sometimes with kids that have parents that are positive. It's a challenge, Kaylin. It's definitely a challenge in peds. It makes it a little harder sometimes. Okay, severe combined immunodeficiency disease. This is a genetic disorder that causes both humoral and cell-mediated immunity absent. So the child is born without immunity and they cannot develop immunity. So basically they have no immune system. It is genetic. They are very, very susceptible to infections early on in life. Most of them also have failure to thrive as they get older. And there is no cure for this. It is management, and then the main treatment modality is bone marrow transplants to basically fix their bone marrow, to keep their bone marrow from working. We will keep them as sterile of an environment as possible at birth. We will give IVIG to help support that immune system before they get the bone marrow transplant. Now, we used to wait until they were older to get the bone marrow transplant, and what we've actually been finding in recent years is that it's actually better to do it within the first 3 months. Does anybody guess why it's better to do it in the first 3 months of life to get that bone marrow transplant? It's still super high risk, but it's not because of mom's blood. Partially because of that immune system. It's because they don't have their own immune system yet, right? It's not necessarily because of mom's immune system. It's because, yeah, they haven't made their own immune system. So there's much lower risk of having graft versus host, of the body rejecting the transplant if we do it within those first couple of months. So we've actually been finding that it's a slightly better outcomes for kids that have this to do that bone marrow transplant early on. David Vedder, Balloon Boy, there was a movie in the 90s called Bubble Boy, kind of based off of his life, and you guys can click on that link if you want to watch more information about him. But he lived in this bubble environment, and he was one of the first patients that went through this type of treatment, and he was basically one of the first bone marrow transplants. He did not survive, but because of his treatment, we now understand why bone marrow transplants failed, why they failed him, and are able to effectively give bone marrow transplants now because of his treatment when he was a teenager. He lived to his early teen years before he was just like, I don't care, I'm so depressed, I've been living in a bubble my entire life. Let's what do you got? It was a sad case. All right, Wiskach-Aldrich is another X-linked recessive disorder. So this is another genetic disorder. Basically, the patient is also immunocompromised. They also have risk of bleeding. So thrombocytopenia is present at birth. This is another one where our treatment is a stem cell transplant, and we'll do platelets and IVIG, potentially splenectomy in the meantime. This is a pretty rare disorder, but it's another genetic disorder that causes immune system compromise. All right, blood transfusions. Big differences here with patients monitoring for signs of a blood reaction, which, you know, you're doing frequent vital signs, you're monitoring for things like blood pressure changes, heart rate elevation, hives, itching, you know, those kind of things. The one thing that I know they teach you guys with blood transfusions with adults is that it has to be given through a large bore IV. Not the case in peds. We give it through small bore IVs. We give it through 24 gauge IVs in peds because sometimes that's all you got. So it doesn't have to be given through a large bore IV, and it can be a very small amount sometimes with peds patients. We still have the same protocols. It can only be run with normal saline. It can only be given over a 4-hour period. You can't run it longer than 4 hours. So same protocols for the most part with blood transfusions with kids. Apheresis is a process where we draw blood, we separate the portions of the blood we either want or don't want, and we can give them back the component that we want them to keep or not keep. This is a process if you go to donate platelets or plasma, they'll take out your whole blood, they'll separate the portion that they want to keep, like the platelets, and they'll give you back your red blood cells. We can use that in the hospital. Sometimes we use that process in the hospital too for patients. All right, practice question. The nurse expects which of the following clinical manifestations of a child diagnosed with severe combined immunodeficiency disease? So what's the main thing with that disorder that I mentioned? D is the right answer on that one. Yeah, they're susceptible to infections. All right, guys, you made it. Woo! If anybody wants to stay on, I'll talk about the most commonly missed test questions on the exam. You are free to log off. Don't forget you have your quiz on Thursday at 2 o'clock, and I will see you guys for class next week. Have a good evening. Hang in there.
I did have a question about whenever we take the dosage calc exam, are we going to be able, is it going to be like the rest of our exams where we don't have the opportunity to go back? Okay.
Yeah.
Just because, like, you know, in class, we like get to go over them again before we turn it in.
I know. And the one thing that I put in my announcement last week, and one thing to keep in mind with like medication management is in real life with a patient scenario, you don't have that opportunity to like go back and double check. You have to learn to do it in real time. So you have to do that double check and that triple check in real time. So just getting used to that and doing that as your process. I don't usually set a time limit on that dosage calc exam when I give it in class. I usually give 30 minutes in class, but if students take 45 minutes, I let them stay and finish it. So you will have lots of time to work on that. It won't be like you have to finish all 7 questions in 30 minutes. You'll have lots of time to take your time with it.
Okay, thank you.
You're welcome. Suggest studying for the cumulative review. Okay, so the cumulative exam, and I'll talk more about this in class next week since it's getting a little bit closer to it. The Red Hesse book is a great overview book for kind of snippets of information, but use your lecture notes as your outline. If it's a topic that I talked about in class, it's a topic that can be tested on. I do give more kind of broad concept questions on the cumulative exam, so critical thinking through that question. If you understand what the disease is, instead of memorizing all the small details about the disease, if you understand what the overriding topic is, it'll help you work through that question. Just like the Hesse is kind of that like broader concept. There will be some specific questions on it, but there's more of those broader concepts on there. There'll be a bigger chunk on the cardiac and hematology stuff that we just talked about this week, since that's going to be new content that you haven't really been tested on yet. So there'll be 20 questions on cardiac heme and then 30 questions that'll be cumulative, as well as 5 dosage questions for that test. So it's 55 questions total. Paulina, confused about how to view the exam? So to go in and view it, if you go to your grade book, you should be able to click on the exam and that should take you to your individual test.
So I've done that and it doesn't allow you to view it. It just says like the score and then you just press OK and it doesn't.
You have to click on, because I don't have the student view side of things, I don't know exactly what it is. You have to click on the score.
Go to your grades and then click on, go to your grades and then click on the blue part. And it should come up.
Okay.
You have to click on the specific percentage and then it will pull up the questions for you.
Okay. Yeah, that's.